All right. Hi, everyone. So today I'm doing kind of like my part two to anatomy. Thank you guys for letting me kind of like record it soon-ish after the last one. I'm like really busy the next several weeks with like exams and stuff. So hopefully this will, whenever you watch it, it'll be really helpful. But okay, so today I'm gonna cover the stuff from last time that I didn't get to. So if you haven't watched part one, watch part one before you watch this one. Um, or you can just skip ahead to like the cranial nerve stuff and the brainstem questions. But I'm going to start with aphasias and lacunar strokes. These are going to be from kind of like what we covered last time, and then go into like the brainstem anatomy and then the blood supply and lesions. And I'll show you kind of like what I mentioned last time with like that foolproof way to literally never get a question wrong on brainstem blood supply. It works every time. But first, here is my correction from part one. It dawned on me like recently that someone asked a question of the ventricle, like if like I think the third ventricle, if it's lined by choroid plexus, and I was like, no, it's not. It is. All of the ventricles are lined by choroid plexus. It's just like that's the definition of a ventricle is that it's lined by choroid plexus. But I think the confusion is that not all parts of all of the ventricles are lined by choroid plexus. And you'll kind of see this when you're doing Dr. White's questions in his roadmaps book. He like harps on that concept. I don't think it's that important, but yes, all of the ventricles are lined by choroid plexus. So I just wanted to put this in here. But okay, so jumping into aphasias. So aphasias are again, it's going to be like a an insult to one of the language areas of the brain. So the most common two aphasias are your Broca's aphasia and your Wernicke's aphasia. I think I showed this slide last time, but just I'll go into it again because there's different types of aphasias, and that's where it gets kind of confusing. And there's this chart that I want to walk you guys through because it's also kind of confusing. But again, there's non-fluent or fluent aphasia, and that basically means you have a problem with talking or not. So Broca's aphasia, you do have a problem with talking. That's why it's called a non-fluent aphasia. Broca's, it's basically the insult goes to Broca's area. Remember we talked about usually it's like an MCA insult because the MCA on the left side of the brain because that's where Broca's area is and it's applied by the MCA. And again, it's non-fluent because there is an issue with speech. And then this is kind of how they remember it. It is a motor issue. Remember, we're in front of we're in like the motor area of the brain, the precentral sulcus here. Like just we're in front of that central sulcus. So that's your precentral. That's kind of like your motor area. Versus Wernicke's, this is more of a sensory issue. It's a fluent aphasia because there's no problem with speaking, meaning like there is an aphasia, but the patient is still fluent. They're still able to speak. It's again a sensory issue because there's an issue with comprehending what's heard, but they respond as if they just say whatever comes to mind. So they say like it's like a word salad. Wernicke's is a word salad, and it's in the temporal lobe. Again, these are both going to be on the left side. Remember the left side of the brain versus the right side, like the physical left side. Like remember, like this is the left side we're looking at because the temporal lobe is pointing to the left versus the physical right side of the brain is a little bit different. So we are talking about the left side. So again, think like left MCA is going to be issues with one of these two areas. And then again, the issues that kind of arise, we talked about the homunculus last time. It's usually due to MCA insults because that's where, especially in the motor homunculus, this is where Broca's area is. It's going to be supplied by the MCA. But in general, so the definition of an aphasia is the inability to understand, produce, or just use language properly. And it's caused by a cortical stroke, again, usually on the left side. There are aphasias on the right side. They don't present exactly the same. I think I mentioned last time, it's like Broca's, if you get a Broca's aphasia, like the equivalent on the right side, it's like you can speak and everything, but you have a problem with like your inflection of how you talk. So you might be like, wow, that's so sad. But like someone with this type of aphasia might be like, wow, that's really sad. Like they can't control the inflection and it might just have to be due because they have an insult on that right side of the brain. So there are like right side counterparts, but Broca's and Wernicke's are usually going to be that left side. And remember, I always put usually with stuff like this because, there's always exceptions. So this is a chart from first aid, and this is kind of like, so you would think like aphasias seem pretty simple, but they'll kind of try and make it a little tricky. So what I mean by that is, to kind of read this chart, the first thing they're going to do is like, is the speech broken up? Is this kind of like a Wernicke? Is this kind of like a Broca's thing? Is it a fluent aphasia, or is it is it a non-fluent aphasia, or is it like a Wernicke's fluent aphasia? So that's one of the first thing. You can think of this as fluent, like they're speaking fine, like how I'm speaking right now. That's fluent speech. There's also, in addition to Broca's, there's also other types of aphasias where they're speaking non-fluently. So again, the broken up word, they're stuttering, stuff like this. And again, kind of how you read this is you put this line here. So fluent's going to be up here, and then sensory is going to be kind of like down here. Your non-fluent's going to be down here. So that's how you kind of break that up right off the bat. You can kind of think of fluent versus non-fluent aphasias as having sensory issues versus motor issues. So non-fluent aphasias, again, Broca's makes a lot of sense with that. You have physical issues speaking. So that's like a motor problem versus a sensory problem. Like you have problems with comprehension, you have problems with synthesizing information. That's going to be more of like your fluent aphasia, but there's still going to be an aphasia component. So that's the first thing is when you're reading the vignette, fluent or non-fluent, then you can kind of visualize this chart. The next thing they're going to kind of ask you is, not ask you, but they're going to mention like, does it seem like the patient knows what's being said? Like, is there good comprehension or bad comprehension? So again, and it kind of splits it down like this. So if there's bad comprehension, that's like a Wernicke's thing, right? It's like they're not understanding. That's why they're just spewing nonsense because they don't actually understand what's being said and they're just like filling the void. They're just like, okay, I'm going to pretend like I know what's happening, so I'm just going to talk. That's like your Wernicke. So a fluent speech with poor comprehension, that's your Wernicke's. There's another type of aphasia called conduction aphasia, and I'll talk about it on like a future slide, but that's going to be, again, you have fluent speech, nothing's wrong with how you're speaking, but now it's like you do have good comprehension. So then you're like, well, isn't that just like normal people, like fluent and they have good comprehension? But we'll talk about conduction. Conduction presents really oddly. And then on the opposite side is if you have non-fluent speech, so like a Broca's, but you understand what's happening, it's just you can't get the words out. And usually these are people that are very frustrated. Like they know what they want to say and they can't. That's your Broca's. So these are the most common too. And then there's another one, it's called transcortical mixed. So this is, again, you have an issue with speaking and you also have poor comprehension. Like everything's hit on that aspect. And the last part of this graph is they're going to ask about repetition. And that goes diagonally like this. I know this graph is really annoying. I don't like this graph, but aphasias take a little bit of time to kind of like read in vignettes and kind of like get down. But I think this graph is a really good starting point, and then you can kind of like work through the vignettes with it. But the last thing is going to be repetition. And repetition, how I kind of remember repetition is always going to kind of require, like if you have an actual area of the brain affected, meaning like Broca's area is affected, Wernicke's area is affected, or like the I don't know if I think I did briefly mention it last time. There's like this tract that goes from Wernicke's to Broca's and it kind of like connects the two. I think it's called like the arcuate fasciculus, I think. Don't hold me to that, but it's in part 1. I think it is the arcuate fasciculus. If that so this connects Broca's to Wernicke's, that's what actually causes your conduction aphasia. So basically if you have an issue with any of these like areas, so Broca's, Wernicke's, or this arcuate fasciculus, that you're going to have poor repetition. So they're going to ask you to repeat something, to like repeat what they're saying. Like, can you repeat these numbers that I'm going to say? They can't do it. That's going to be on this side, this left side of the chart. So that's going to be, again, arcuate fasciculus, Broca's, or Wernicke's. And then if repetition is fine, I usually think of that as like an area is not affected. It's like other things are affected, which we'll talk about, but these are all your transcortical ones. So your transcortical sensory aphasia, your transcortical mix, which is like a mix of both sensory and motor, and then your transcortical motor aphasia. Okay, and they have no problem with repetition. Okay, it's a lot, I know. So then I, again, kind of just used first aid because I think it's really nice and simple how they break it down. Again, there's more words because, of course, there's more ways to describe these things. So remember, Broca's is your non-fluent. Another way that people say it is expressive because the issue is with expressing. It's with actually speaking. And here's the definition of that. We already kind of talked about it. And then remember, there's an issue with repetition. So I kind of added that to the first aid notes. So you can't repeat. Wernicke's, this is a fluent aphasia, and it's a receptive aphasia because, again, the reception of the information is the problem. Speaking's not the problem. There's no problem with expressing. Kind of everything we've talked about, and again, also cannot repeat because, again, we're breaking like an area. We're actually like hitting in one of these areas. And then you have a global aphasia. This is a non-fluent aphasia. It's basically a mix of Broca's and Wernicke's. So, of course, it's going to be non-fluent because you're not going to be able to speak because Broca's is affected. But it's not conduction aphasia. I want to point that out. Global aphasia is not conduction. This is usually going to be like a separate Broca's is hit and then Wernicke's is hit. And usually what happens here is it's kind of weird because it's like Wernicke's is affected, but again, think of it, they can't speak and they can't understand what's being said. So the patients usually mute, they usually just like mutter sounds and they don't actually formulate words. It's kind of like it's like the worst of both. So that's your global aphasia. Your conduction aphasia, like I said, it is the arcuate fasciculus. I don't know how, yeah. So Broca's to Wernicke's gets connected. There's this tract here, and then it itself gets severed. So this is different from global because again, we're not affecting Broca and Wernicke's itself. We're affecting the tract. So if you think about it, it's like Broca's and Wernicke's can't talk to each other, and you need both. You need to understand with Wernicke's and then speak with Broca's area. It's like the sensory and the motor. So now we're severing that connection. So the arcuate fasciculus is in the parietal lobe, and I put this here in case like they even mention like there's a parietal lobe issue. You can think like, oh, maybe I should be thinking of like the arcuate fasciculus, maybe, because again, Broca's is in the frontal lobe, Wernicke's is in the temporal lobe, and now we're in the parietal lobe. So we're in all the different lobes of the brain. So something that's interesting here is that speech production is fine. Because again, we're not physically breaking Broca's. We're not physically like affecting Broca's. Speech production's fine. On the contrary, the comprehension is fine because again, Wernicke's is not affected. Wernicke's is good, Broca's is good, so we can speak, we can understand, but the only kind of the only kind of indication that this is going to be a conduction aphasia is you can't repeat. And the best way to kind of just understand that is you need both understanding of what's being said to you, and you need to like connect that to what you're going to say because you're not formulating your own thoughts when you're repeating. You're just kind of like hearing what you need to say and then saying it. So this is going to be pretty much your only symptom with a conduction aphasia. Okay, it's going to be like they can't repeat. Hopefully that makes sense. Again, it's going to take a little bit of time to kind of like work through this chart and be like, okay, fluent, non-fluent, comprehension, no comprehension, repetition, not repetition. Usually repetition gives it away because if they can't repeat, it's three things. It's really only three things. Then you can kind of like figure out like, okay, is there a problem with speaking? Is there a problem with understanding? Or is it like is it an arcuate fasciculus lesion? These transcortical aphasias, I even put here that they're low yield because they really are. The only reason I kind of kept this in here is because you might see them as answer choices. They might be answers to questions, they might be, but they are on the lower yield side, but we're still going to talk about them. But I talk about how basically you have brain damage that's going to result in the separation of language centers from other cortical areas that are involved in speech production and comprehension. So what I'm trying to say by that, it's like it's not Wernicke's and Broca's, but there are a lot of other speech areas in the brain that all kind of like feed into like being able to speak and understand and whatnot. And this brain damage is like affecting those areas. It's like the low yield. It's literally like a low yield aphasia because it's like the non-main like word areas in the brain are being affected, and that's these types of aphasias. All three of these, so all three transcorticals, there's going to be good repetition. And again, this is kind of how you distinguish it from like those typical higher yield aphasias we just talked about. And then going through it, they do kind of match up a little bit. So for example, like transcortical motor, this is going to be a non-fluent aphasia. So it is going to kind of almost present like a Broca's, right? It's going to be non-fluent, but they can repeat. Like you ask them to say something, they repeat it. You're like, oh, that can't be Broca's. Broca's, they can't repeat. So kind of like this transcortical aspect is like it's the frontal lobe around Broca's, but it's not Broca's. But it does present like Broca's, but they can repeat. So repetition becomes a really good way to kind of like parse out which of these aphasias it is. And then transcortical sensory, again, Wernicke's is a sensory aphasia, so it's going to be very similar to Wernicke's, but Wernicke's is not affected. And then mixed is going to be kind of like your conduction. No, it's going to be more like your global aphasia. So again, it's going to be non-fluent, but everything's fine. Broca's is fine, Wernicke's, the arcuate fasciculus. And they talk about like these watershed areas are affected. It's basically like this part, like this frontal lobe around Broca's and this part, this temporal lobe around Wernicke's are both affected. So they call that like a watershed area, but the actual areas are fine. So again, it's going to present like a global aphasia, but now the repetition is totally fine. Yes, repetition is totally fine. And then here's a chart. I feel like this was from Dr. White. I think that's where this is from, but he's kind of, if this is from him, he kind of makes this chart. He goes through it because again, this is all you really need to figure it out in a vignette is like, okay, can they talk or not? Cool. If they can't, it's like nice, we're in Broca's, or like, we're in like a conduction, or we're in like a transcortical mixed. And then you kind of go through you kind of go through just this chart and go through those three things. But the main thing to remember is about this arcuate fasciculus. If it gets damaged, each individual place is fine, but you need both working at the same time to repeat, and that's why you have problems with repetition. That's pretty much it with a conduction. All right, those are aphasias. Nice and easy. So we're gonna do lacunar strokes next because I wanted to talk about these last time, but there wasn't enough time. So remember, like I said last time, lacunar strokes, these are like a lacuna is like a little lake. So these, remember, we have our MCA, and then we have these little tiny baby blood vessels coming off the MCA. We're going to talk about those today, like what those are called. These get damaged in lacunar strokes. And the reason they call them lacunar is now whatever area of the brain it's supplying, which is usually like a really tiny area of like the deep structures, it is going to lose oxygen because now it doesn't have blood. So it like basically turns black or white on like an X-ray or MRI, one of those clinical things. It's going to turn and then it's going to look like a lake because now there's an area that doesn't have blood, doesn't have oxygen. That's where it gets its name, but it's these really tiny areas. So I think I got this question last time. The lacunar strokes are not this. I'm going to talk about a type of lacunar stroke, but it's not the only one. I'm talking about the ones coming off the MCA, specifically what I'm drawing here. But if you see this term, like a lacunar stroke, all they're talking about is like a stroke of really tiny blood vessels that are supplying really tiny regions of the brain. Okay. So this was from last time. These are just those slides from last time. But again, the ones I'm going to talk about are specifically the ones that are supplying the basal ganglia and the internal capsule. So I have here, they're supplied by small branches or arterioles that come off the MCA and the ACA. I put ACA, I never have gotten a question on this, but I guess it is possible, so I included it. But MCA it's always MCA. It's like one of those like, I don't always say always, but like it's always MCA. And then sometimes I see ACA sometimes, but usually it's MCA. And specifically what I'm talking about, these are called lenticulostriate vessels or lenticulostriate arteries. Yes, they're technically arterioles because they're really tiny. But the lenticulostriate is specifically these little baby branches coming off the MCA, and they're supplying the basal ganglia and the internal capsule. So we did talk about a little bit of like, caudate nucleus, putamen last time, and the internal capsule. But if you don't remember, that's these structures here. So here's one here. Here's another like basal ganglia structure. And then the internal capsule runs between the two. It kind of looks like that. So the reason I put this with last week's stuff is technically if you have an MCA stroke, like technically if you do, you can take out all of these lenticulostriate vessels. So technically you can see whatever I'm about to talk about right now, you can see that in an MCA stroke as well. Sometimes in an ACA, and I said I guess it's still possible. It's usually if you see it in a vignette, it's going to be in an MCA. Or, and I think I put a question in here later for you guys to do, hint, hint, or you don't see MCA signs at all. You just see just the lenticulostriate arteries get taken out without any MCA symptoms. That's a lacunar stroke. Does that make sense? So it's not like, I wouldn't call an MCA stroke with lenticulostriate arteries like being taken out. I wouldn't call that a lacunar stroke. I only call it a lacunar stroke when these are the only things being taken out and like the MCA is fine. And we did mention this last time, I think a little bit, but how that would even possibly happen is when you have, like high blood pressure or something, or you have not coronary artery disease, but like, I think maybe, but like, yeah, arterial disease in the brain. I think that's coronary artery disease. But when you have like that and you get like hyaline deposits on these vessels and they can just stop working because they're so tiny. So think about getting like lipid deposits in like very tiny vessels. It's just like that's done. And then you can get like these symptoms of a lacunar stroke. So specifically with this, I wanted to talk about the internal. This comes up more frequently than I think people realize about the internal capsule. And this is going to be, you'll probably cover internal capsule when you talk like more about basal ganglia and the functions of it. But there are like there's three parts technically of the internal capsule: the anterior limb, the genu, and the posterior limb. And it kind of like, I draw it kind of like this. It has like a bend. The anterior limb is the closest to the top of the brain, obviously. The genu is going to be like the bend where it kind of like runs around a bend. And then the posterior limb is going to be down here. And each limb, which is really annoying, each limb has a different function, which is hilarious because of the structures, the different structures that run through it. So, for example, the anterior limb up here has the thalamocorticospinal tract. The thalamocorticospinal tract is an ascending tract. And again, I didn't go into tracts because that's not this session, but this tract specifically is sending sensory information from the thalamus up to the cortex. And if you ever are like, I don't remember if that's an ascending tract, a descending tract, always look at the name. So like, for example, thalamocortical, the first part is always going to be where the tract starts, and the second part is always going to be where it goes. So like the thalamocortical, this is coming from the thalamus going to the cortex. So if I'm sitting here and I'm like, oh yeah, this is, again, sensory information from the thalamus going up to the cortex. That's an ascending tract because you need to go up from the thalamus to get to like the cortex. The genu contains the corticobulbar tract. We're going to talk about this today because this is your cranial nerve tract. This is a descending tract because it comes, again, cranial nerves, they come from the brain and whatnot, and they all pass through the genu of the internal capsule. So that's this part here. And so you'll see maybe some cranial nerve functions will be damaged with this. But the most high yield, and that's why I like highlighted, bolded, did all this stuff to it, is the posterior limb of the internal capsule. This is the one that I see the most questions on, like just all the time. This contains your corticospinal tracts, which again, we're not talking about today, but that's your major descending motor tract. That's like tells you basically what's going on motor-wise with the body, and your thalamocortical tract. So again, another sensory tract from the thalamus up to the cortex. Interestingly, since it contains, and again, all of the corticospinal tracts in the entire brain run through the posterior limb. And a lot of times people ask me, they're like, well, how does it only run through the posterior and not through the anterior, the genu? I honestly have no idea, but it's kind of like a posterior limb of the internal capsule I want you to associate with the corticospinal tracts. Like this is like the motor limb. So if it gets damaged, just think about the posterior limb of the internal capsule getting damaged, no motor function. Basically, motor function is gone. So that's like a big, they call these pure motor strokes. So pure motor strokes, because the only symptoms this patient has are motor symptoms. And you're like, that's really odd. Because if you start doing questions, you're going to see it's a little bit of motor, it's a little bit of sensory, it's like some cranial nerve stuff. Like you're like, it's really weird when it's just pure motor or pure sensory. This is an example of a pure motor stroke. A question I always get too is like, what about like a pure sensory stroke? That would be a thalamic stroke, because again, I don't know how far into this you guys went. I didn't want to talk about physio too much, but all of the now sensory information from the entire body goes to the thalamus. Basically, it has to relay through the thalamus before it goes to the rest of the brain. So you can see pure sensory strokes if you take out basically the tracts that go from the thalamus, or you take out the thalamus, which is another type of lacunar stroke. But again, taking out the posterior limb of the internal capsule, that's going to be a pure motor stroke. So again, only motor symptoms are going to be like presented from the patient. Sensory symptoms are intact. And again, I even tried to find one to put it in here. I've never seen a stroke of the anterior limb or the genu. I've never seen it. And again, if you're going to get a question on like a lacunar stroke, it's going to be the posterior limb of the internal capsule. All right. But I just wanted you to be aware that there are other ones because they have their own kind of like blood supply. But since we're talking about the lenticular striate vessels, yes, the posterior limb is supplied by the lenticular striate vessels. And this is a really complicated photo. I apologize. It's just hard to find good pictures of this stuff. But just to kind of show you, they did color code it, which I appreciate. But if we're looking now on if we're looking down at the brain, this is like the right side of the brain. So we're looking down onto it. So this would be the internal capsule right here. And so we have like, they color coded it like everything in yellow, that's the anterior limb. The blue is the genu or the bend. And then everything down here is the posterior limb. And you can see everything is supplied. Well, all of these are supplied by the lenticular striates, but they give you some other arteries that supply it. So for example, the recurrent artery of Hubner. Sure. But like, again, low yield. The most important is going to be down here, your posterior limb. This is usually always going to be supplied by your lenticular striates, which come off the MCA, which is kind of showing you somewhere right here. So they drew it. So this is your MCA. It's supplying all of them, or it should be at least. And then also there's another artery called the anterior choroidal. This will come up when you guys get to like different types of like aneurysms, like berry aneurysms, which should be more of like a path thing you're going to cover later in the block. The anterior choroidal will come up again. And so many people accidentally call it the ACA because it is like ACA. But remember, the ACA is your anterior cerebral. That's one of the main three. The anterior choroidal, they usually abbreviate it ACHA. So I just wanted to put that little thing out here. So again, I put here strokes of the posterior limb of the internal capsule, pure motor stroke. And I do think I put an example of it in the question, so you can go find it later and be like, well, how would that even present? And then again, I wanted to show how close the internal capsule is to the thalamus. So again, we have like the caudate nucleus. We talked about this last time. The lentiform nucleus, which is, these are just parts of the basal ganglia. And then here's your thalamus. And then internal capsule, anterior, genu, posterior. So again, you can have these pure thalamic strokes, but that's really not going to have much to do with the internal capsule unless you have a really bad internal capsule, like a really bad internal capsule stroke. It could bleed into the thalamus. I hate to like leave it so up in the air, but a lot of the times, like, it's going to be just like doing questions on this. It's like, okay, how do I know if it's a pure motor stroke with a sensory component because it bled into the thalamus, or if this is just like a normal stroke? And you'll start to see, and that's why I even put on here, like, normally the posterior limb of the internal capsule is supplied by, again, the MCA primarily, and then the ACHA, or your anterior choroidal. And the lenticulostriate arteries supply these structures, parts of the internal capsule, lenticulostriate, and then it'll kind of go into, I don't know if it talks about the pure motor stroke here, but what I wanted to point out was, again, a pure motor stroke, posterior limb of the internal capsule, again, always. Pure sensory stroke is just when you take out the thalamus. But then you have, and this is again where questions are a little tricky, a sensory motor stroke, which you're like, isn't that just, every single stroke that people have is like sensory and motor components that aren't like these really tiny, like baby strokes? It's gonna present as primarily a motor stroke. So it's gonna sound a lot like a pure motor stroke, but then you're gonna have like little indications of like thalamic strokes thrown in there, which is confusing. And when you guys get closer to your exam, I actually have a really good question that highlights this to kind of show the difference between that and others. But I wanted you to at least be aware that that can happen. So I just wanted to mention it here. But a lot of the times, just kind of get used to like recognizing these pure motor strokes. That's going to be posterior limb of the internal capsule. That's going to be your lenticulostriates, and it's going to be those little arteries coming off the MCA. All right. So that was everything from last time. Hopefully that makes sense. And we will, again, I promise we'll talk about those sensory motor strokes later. They're just like a really niche topic of like neuro that like, that can be like honing in on your neuro skills right before the exam. But today, primarily wanted to talk about your cranial nerves and your cranial nerve palsies. And then we're going to talk about it in terms of brainstem anatomy and then the blood supply and then lesions. We're not going to do the questions, but I do want to walk through my like tic-tac-toe method I'm going to teach you with at least one question so you can see like how to use it and like answer these questions. So here's my little like, what do I think you need to know about cranial nerves? And this is like stuff that I made like Quizlets for before the exam, flashcards, like whatever. But remember, we did talk about this last time. Cranial nerves are peripheral. So everyone thinks they're central because they're up in the brain, but technically they're peripheral nerves. So again, if they were to ask about, myelination of the cranial nerves, the Schwann cells are going to myelinate them because Schwann cells myelinate your peripheral nerves versus oligodendrocytes, they myelinate your central nerves, like nerves of the central nervous system. Okay, so I think of cranial nerves as just peripheral nerves that just so happen to be located, where the brain and the brainstem are, which are, two of the parts of the central nervous system. But here are the things to know. So names and numbers. So what are the names? What are the numbers? Yes, Roman numerals count. Like sometimes you'll have questions where they'll just go like, cranial nerve 7, and they'll write it out like this. They won't actually write the number 7. So I try to do Roman numerals whenever possible. Because, think about how silly it is to get a question wrong just because of Roman numerals. Like, come on. You don't want to do that. So do learn the Roman numerals, and they will put Roman numerals on your exam. They do it on boards. So just whenever you see it, just try and just remember to like, what is the Roman numeral for this number? What are its nuclei? Cranial nerve nuclei, there's a lot of them. We're going to do them today. They're going to take a while to go through. So our cranial nerves from neural tube or neural crest. Good question. So peripheral nerves, they are going to, I don't actually know. Probably neural crest if I had to guess, but I don't remember off the top of my head with, development and whatnot. But they're gonna arise from wherever the peripheral nervous system is arising, if that helps. Hopefully it's one of those two. I am gonna do like a development lesson lecture thing, like development of the CNS and PNS. So I'll 100% include that in there. Okay. Their nuclei, there's a lot for the nuclei, so just there's a lot for nuclei, but we'll talk about all of them. Is it a motor cranial nerve? Is it a sensory cranial nerve? Does it do both? What are its functions? We're doing this. White goes into so much depth about functions, but I'm going to go into it a little bit today. I'll give you like one slide on functions. Locations, is it in the brain or in the brainstem? There's 2 in the brain. Everything else is in the brainstem. If brainstem, where, and then are they medial or lateral? This is going to help you with your brainstem lesions that we're going to do at the very end. Okay. And then where do they exit the skull? This one you'd think is low yield, but they always usually ask this on like board exam, your ComSci, your COMAT, they usually ask this, which is really odd. And I have like a way, everyone used like one way to remember where they exit the skull. So I have it on here. I'm not going into this right now. This is for you guys for later. But this is pretty much everything we're talking about. We're going to be talking about with the cranial nerves. Okay. So this is for later. I know it's blurry, but this is the mnemonic that I use to remember. So basically it's like, are these sensory or motor? And again, this is really important for when it comes to those brainstem lesions. So you just kind of draw them out in order. So 1 through 12. And then it's the mnemonic people use, or like the phrase people say. You might have done this in like college if you took like a physio class in college. But like some say marry money, but my brother says big brains matter more. And it's just like sensory, motor, or both. And you'll start to like just not even have to say this, and you're like, you just know off the top of your head, like, oh yeah, the olfactory, like smell is a sense, it's not a motor function. So like some of them are intuitive, but some of them have two functions, like cranial nerve 8, for example, or sorry, cranial nerve 9, which is going to be your, oh, sorry, I need to open the chat. Yeah, so I know, so the question, I'm going to say it for the recording, so he's saying that, or you're saying that in Dr. White's lections, he said that 8 is both. So should we listen to that or what everything else says? I know why he says 8 is both. I actually almost if you guys caught me, I almost tripped up and said 8 was both, like right there. Technically it is both, technically. Like there is a motor component, but basic, like for testing purposes in terms of like when you test the cranial nerves, when you learn them in H&P, it's more of a sensory kind of, it's more sensory than motor. I remember even in my neuroanatomy class for my PhD program, my teacher was like, technically 8 is both, but for purposes of like learning it and like testing it clinically, it's going to be a sensory. That's a good question. He is right. It is both, and it does have motor functions, but the motor functions are really more so for like steadying yourself with like, vertigo type presentations. But a lot of cranial nerve 8, and this is like the nerve for hearing and like for balance, that's really, really heavy on sensing, like sensing your environment and hearing sounds and whatnot. So basically, I'm trying to say I would go with sensory, but just know when you're doing his questions and stuff, he might call it both, and that might like affect, his questions. But I really think, and when things like this happen in like the PBL world where it's like there's all these different resources, I usually say do what UWorld says, but UWorld's second year for you guys. But whenever there's a discrepancy with like lectures or first aid versus like something Dr. White says, for example, me and my friends were always like, whatever UWorld says is what we go with. I feel like even UWorld was like, it's just think of it as a sensory nerve. Yeah, no problem. Sorry for that long rant, but I almost tripped up too and said it was both because I was like, oh yeah, it technically is both, but like it's more sensory, and that'll help you with the lesions that we're going to talk about later too. Okay. So here's again, we're looking at the brain. Remember, this is you take the brain and then you flip it. So this is the front, and we're looking at the ventral part, right? Terminology. So we're looking at the ventral part of the brain, so underneath the brain, at like basically the belly of the brain. And this is all of the cranial nerve. So everything in, they basically cut away they cut away the blood supply that we talked about last time, and here is just everything in yellow is a cranial nerve. And what I wanted to point out was they go in order. You might have heard of like the rule of threes. I don't really do the rule of threes. I kind of do the non-rule of threes or the rule of fours. I forget what I think it's the rule of fours. And it's like there's four like above the mid, like including the midbrain and the cerebrum. There's four in the pons, and then there's four in the medulla. But they all go in order. So if you just kind of like remember, like you can think of it the four, because they do kind of switch. So for example, like the olfactory nerve, which is cranial nerve 1, and the optic nerve or the optical nerve, according to this picture, cranial nerve 2, these are not in the brainstem. So when we talk about them in a little bit, I'm actually going to say like with brainstem strokes, like the olfactory nerve and the optic nerve are never affected, and that's why they're not in the brainstem. Everything else is. So oculomotor and trochlear, these are a part of the midbrain, so that first part of the brainstem. Trigeminal, abducens, facial, and vestibulocochlear, those are in the pons. And then the last four are in the medulla. So 9, 10, 11, and 12, glossopharyngeal, vagus, accessory, and then hypoglossal are all going to be a part of the medulla. So this is what they kind of say, like break it up into like fours, because they do go in order, which is really nice. I forget if you guys will have questions in terms of like they point to this nerve. Definitely on boards. I just don't remember on your exam if they did this. But again, like when in doubt, they go in order. And I always try to find the trigeminal nerve because it's massive, like it's huge. Like this is the trigeminal nerve. And then I'm like, okay, this is 5. So I can kind of go in order, like 6, 7, 8, 9, 10, 11, 12. Yeah. So, and then above it, like 4, 3, 2, 1. So they do kind of go in order. It's not bad. Try to find your trigeminal first, and then it'll make all the other ones easier. And then roughly, like, remember the big bulge is the pons, so you know there's 4 that are going to be around the pons. It's going to be 5, 6, 7, and 8. So if you had to guess, you can kind of like you can pick one around like what brainstem structure it's near. And then again, medial or lateral. So you'll see what like medial lateral means when we get to like physical brainstem anatomy. It's like when you look at a cross section of the brainstem, is it medial in the brainstem or is it lateral? Again, the only reason this is important to know is because it's important for lesions. So kind of like here, again, remember 1 and 2 are not in the brainstem, so they're not going to be affected by any brainstem lesions at all. And then here's like medial, lateral, medial, blah, blah, blah. So the medial brainstem cranial nerves that are medial are all factors of 12. So again, excluding 1 and 2, because they're not in the brainstem, it's going to be everything that's a factor of 12. So 12 is divisible by itself, cool. 6 goes into 12, cool, it's medial. And then 3 and 4 both go into 12. So those are your medial cranial nerves, and then everything else is going to be lateral. This is important when we draw our tic-tac-toe like board later for the lesions. You're going to draw in the cranial nerves and if they're medial lateral. So that's why it's good to know this. This is where they exit the skull, which you're like, why? That can't be important. You're like, that just can't be important. But we're in the business of high yield here, and this is high yield. This is like, again, something that they asked a lot for some reason at like the FBS COMAT that you take at the end of your first year. I think you guys still have to take that. I don't even remember, or I don't know anymore. But they did ask a lot about this, like where all these things exit the skull, and you're just like, I don't even know skull anatomy. Like, I don't know what all these, and basically it's like literally like where they pierce through the skull. There's like fissures, there's holes, there's all sorts of things. And so how people remember it, because this is a mess, just like looking at this picture is a mess, is this kind of mnemonic. And again, everyone was saying this like during our COMAT first year, but so they basically write all the cranial nerves in order. There's 3 branches of cranial nerve 5. So it gets 5, like it gets on here it gets on here 3 times. But you draw out 1 through 12 with 3 5s. And the mnemonic is come on, Sophia, 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 roll over, Sophia, I am in a mood, jug, 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 hey. Which, I mean, it works. It does work. Other ways people remember this stuff is the 3, 4 cranial nerve 5. Some people remember it as standing room only. because it's three, each branch of cranial nerve 5 exits in a different part of the skull. So that, I think this is what first aid says, like standing room only for the 3 for 5. And then what they line up with. So like standing is the superior orbital fissure, room is the foramen rotundum, and then only is the foramen ovale. Okay, so this is what the mnemonic or the way to remember it is, and then this is what the actual physical part of the skull that it exits is, like what it lines up with, if that makes sense. And straight up, sometimes it'll just be like a question like, where does cranial nerve 7, where does the facial nerve exit the skull? The internal acoustic meatus, done. Okay, so just put this in here. There's a lot of mnemonics with neuro. These are all things, and I'm putting them like in the front of like your studying, because this is like these are all like anatomy things, but this is all stuff that I made flashcards for like right before the exam, just to be like, okay, we're gonna just memorize this before the exam. All right. So I think hopefully that's the last thing of just like straight memorization. But the last thing before we dive into the cranial nerves is to talk about the corticobulbar tract, because the corticobulbar tract is your cranial nerve tract. It's a motor tract, so it is motor. And it's going to be, it again is going to be the one that basically has all of the cranial nerve fibers going through it. So like I said, cranial nerves are part of the peripheral nervous system. So how you can kind of think about this is what I drew over here. Well, I didn't draw this, but this is kind of what this picture is. It's saying there's these upper motor neurons that are in the motor cortex, because again, these are all motor functions. And then the axons are traveling together as fibers. That's kind of what they're showing here, like these fiber tracks when they travel together. They all go through the internal capsule. And I think the corticobulbar tract is like the anterior and the posterior parts of the internal capsule. And then they all branch out as cranial nerves. Okay, so that's kind of just a brief overview of corticobulbar tract. Again, I know White goes into a lot of detail with this tract, but it is a motor tract, and the cranial nerves have their own tract, basically, and that's what this is. Another thing, too, that's really important about the cranial nerves, and this is going to be important, again, with our brainstem lesions later, with our tic-tac-toe method later, is they are, when cranial nerves kind of like, well, the corticobulbar tract, the tract itself is like, it sends out a contralateral branch and an ipsilateral branch. And cranial nerves, again, since they're a part of the peripheral nervous system, they act a lot like lower motor neurons. Because again, the corticobulbar tract starts with these upper motor neurons up here, and then they go through the tract, and then they end as cranial nerves. You can kind of think of cranial nerves as like these lower motor neurons. You're not going to see lower motor neuron signs. We're going to talk about the lower motor, like the cranial nerve palsies. Those are the signs you're going to see. But just in terms of thinking about it, they're kind of like lower motor neurons. So if that's the case, that's why if you have a cranial nerve issue, it's going to be ipsilateral. So if I have a left-sided cranial nerve, like, I don't even know, 6 issue, it's going to be ipsilateral to whatever cranial nerve is lesioned. Okay, so if the left cranial nerve 6 is lesioned, I'm going to have left-sided issues. And remember, this is opposite from what we talked about last time. Whereas like if you have a upper motor neuron on the right side, like a tract lesion on the right side, you're going to see symptoms on the left side, and vice versa. With cranial nerves, it's always, always, always ipsilateral. All right, and then 7, there's like a weird exception with 7. We'll talk about it when I go into 7. But that's kind of what this is showing here, is that this entire corticobulbar tract goes through the internal capsule, and then it sends out branches both contralaterally and ipsilaterally for all of these. All right. Okay, and then 7, remember, weird exception, we'll talk about it. All right, hopefully this makes sense. But again, this is more so to just tell you it's kind of like, and then again, where they synapse, it lines up with the 4, 4, and 4 method. So it's the same thing. 7's the exception. And then we're going to talk about, again, the main thing here is ipsilateral. So again, cranial nerve on the left side is lesion. You're going to see left-sided symptoms, and vice versa. Right side lesion, right-sided symptoms. And again, when we do like a tic-tac-toe method later, I'll show you like that's like, I'm like, here's an example of like the cranial nerves being affected on one side, but one of those long tracts, like your corticospinal tract or your like spinothalamic tract getting lesion is going to affect the opposite side. So stuff like that. All right, so cranial nerve 1 palsy, this is your so cranial nerve 1, this is your olfactory nerve. Remember, it's a sensory nerve. If you lesion it, you can't smell. There's your cranial nerve 1 palsy. This is not a brainstem lesion symptom. This is not going to be in our tic-tac-toe method at the end. This is also interesting, like when COVID, like when the alpha variant of COVID first hit, people were losing smell. They were getting anosmia, and they think it's because like how COVID was replicating, it was getting into the olfactory nerve and it was replicating in the like in the nerve, which is wild to me. But it was replicating, and that's why people were losing their smell. That's why they were saying it was a really early sign of COVID, because remember, the virus has to replicate before it's able to have enough of a viral load to cause symptoms. So that's again why like the earliest sign was anosmia, because that's when it was replicating. And then like the next day people would be really, really sick. Which is a fun fact. So cranial nerve 2 palsy. So your cranial nerve 2, this is your optic nerve. This is a sensory nerve. This is what allows you to see. And then this is not going to be a brainstem lesion either. There are tons of stuff that goes into sight and seeing, and that's going to be something later because the eye is very, very complex. But again, all this to say, we're not talking about these today because these are not part of the brainstem. All right, so the first one we're going to talk about today, like the main one for the brainstem, is cranial nerve 3. So cranial nerve 3 and a palsy. So like if you lesion cranial nerve 3. So cranial nerve 3, your oculomotor nerve, it's a motor. It divides nicely into 12. It also has motor in the name, which is nice. And again, this is what you should be doing when you're learning these, like, and trying to get these down. What's the Roman numeral? What's the actual nerve called? And then is it motor? Is it sensory? And like medial lateral kind of thing. Oh, motor is not, that was medial lateral dividing by 12, but it worked. Another thing about cranial nerve 3 is that it also contains parasympathetic fibers, and it's called the Edinger-Westphal nucleus. I don't think I go into this today, but there is an implication in terms of like if you do lesion cranial nerve 3, you can see parasympathetic signs of like eye stuff because spoiler alert, oculomotor, this is motor movement of the eye, oculo. So it affects, if you lesion cranial nerve 3, it's going to affect like motor function of the eye. But there's this parasympathetic fiber tract, and literally it's like if this is cranial nerve 3 running to the eye, basically from the midbrain, it's going up to the eye. There's like it's like a tract that runs right along with it. A lot of people don't even draw it in there because it's like it's right on top of the nerve. That's your Edinger-Westphal nucleus. It's just a nucleus of cranial nerve 3, and I'll show you what it looks like when we do like a cross section of the brainstem. It's one of its nuclei. And so if you also lesion cranial nerve 3, a lot of the times you lesion Edinger-Westphal, which is this other tract that runs with it, and you see symptoms of lesioning parasympathetic. So like you'll get like mydriasis, like your eyes will just like go, like your pupils will go really, really, really wide because it's like you lesioned parasympathetic. I might have said that backwards, I forget. But whatever parasympathetic normally does with the eyes, you lesion it, it does the opposite. Should have looked. The sympathetic parasympathetic always confuses me with the eye, but I think lesioning it is gonna, yeah, okay. And then lesions of the motor. Oh, wait, hold on. Oh no, I think it is right. I think it, yeah, okay. Ignore me. We'll talk about it. I think I have it on the slide. But if you lesion the motor portion, what I mean by this, the motor portion is going to be the portion that's running along with Edinger-Westphal. It's like the true cranial nerve 3. That's the motor portion of it. And again, Edinger-Westphal just kind of like runs next to it. Oh, I talked about it here. All right. But anyway, so the motor portion itself, here's all the things that's going to be affected. So you're not going to be able to adduct, so adduct. So you're not going to be able to bring the eyes in. That's adduction. No, out. Oh my God. Oh, always forgetting. In. You can't bring it in. That's adduction. I'm trying to think of like the adduction machine at the gym. All right. So adduction, you're not going to be able to go in, like look in, like literally look cross-eyed. You can't do that. Like you can't bring your pupil looking in to like where your nose is on either side. So having this adduction weakness, they call this internuclear ophthalmoplegia, which is a ridiculous word. But internuclear ophthalmoplegia, or INO, again, I have a picture showing this, but it's again, you have issues with adduction of your eye. And a lot of the times when they say like you lesion the motor portion of cranial nerve 3, you'll have a down and out gaze. Because again, it's like the only thing now that's affecting it is abduction. So it's, which again is a different nerve. It's not cranial nerve 3. So it's going to be pulling it out and there's nothing balancing it. There's nothing pulling it back in because we lesion cranial nerve 3. So it's going over here and then it's like looking down. So it's like a down and out kind of gaze. This is like clinically how you can tell like someone has a cranial nerve 3 lesion is they're just looking down and out. So like, yeah, that way. They're gonna have ptosis, so the eyelid's gonna droop because again, that's part of what cranial nerve 3 does. It's one of its. I don't remember if it's parasympathetic. I think it's just another nerve that's a part of the cranial nerve 3 like motor network. It keeps the eyelid from not drooping, which we'll talk about. And then you can see horizontal diplopia, meaning that if you try to have them look horizontally, they're gonna be cross-eyed because again, you need adduction to do that. So it's gonna cause cross-eyedness if you don't have adduction. So you see horizontal diplopia. And again, motor fibers are going to be in the middle because again, when cranial nerve 3 is like drawn, it's usually like the cranial nerve 3 motor portion is in the middle, and then Edinger-Westphal, the parasympathetic portion, is going to be on the periphery or like on the outside of it. And honestly, sometimes they will draw it. Like they'll draw like a big thick nerve and then they'll draw like a little thing next to it. That's usually like on the periphery. That's going to be your Edinger-Westphal. That's just traveling with it. If you lesion only the parasympathetic portion, which again usually does not happen, usually it just happens along with lesioning this big motor portion, you're gonna have absence of parasympathetic functions with the eye. So for example, absence of pupillary reaction. Again, I think you get mydriasis. It could be meiosis. One, it gets bigger, one, it gets smaller. Whatever the parasympathetic normally does, you lose it, and now the other thing is gonna happen. And then the brainstem lesion symptoms are going to be if you lesion the medial midbrain. This is when you're going to see, and again, brainstem lesions are all about understanding the cranial nerve. So it's like if you see these symptoms in a patient and they're asking about a brainstem lesion, they're talking about this is occurring in the medial midbrain because cranial nerve 3 is in the midbrain and it's in the medial part of the midbrain. So it's like, and you'll see with the tic-tac-toe method. But this is the picture kind of showing a cranial nerve 3 palsy does a lot of the motor functions of the eye, not all of them. But here's all the muscles that it has in red. These are all the ones that the cranial nerve 3 innervates. So definitely know those. So your inferior oblique muscle, your superior rectus muscle, medial rectus muscle, and inferior rectus muscle. Okay, so that's the only ones that cranial nerve 3, there's 6 eye muscles, which is crazy to me still, that there's 6 that control eye movement. 4 of them are like taken out when you lesion cranial nerve 3. Lateral rectus is 6 and superior oblique is 4. So we'll talk about those when we get to cranial nerve 6 and cranial nerve 4, but definitely know the 4 that cranial nerve 3 takes out, like what those muscles are. And then again, you're gonna have issues with adduction, adduction. So if this is midline, you can't so on this so this is the person's left eye, this is their right eye because they're facing us. And you basically tell the patient like, hey, look over there towards the right, like look towards the right. And this eye just stays staring at you. And you're like, nice, that's no adduction. And again, remember, cranial nerves are ipsilateral to the lesion site. So for example, I would look at this first picture here and say like, oh, it's a left-sided cranial nerve 3 lesion. Like this patient can't adduct when I tell them to look that way. That what I'm just talking about right now, like the inability to kind of like adduct, but the other eye's fine, that's your internuclear ophthalmoplegia. So that's kind of that's just a fancy word that they gave to it. Like one of the eyes can't adduct, but it's always going to be the lesioned eye can't adduct. And then if you asked it to go the other way, so if you ask them to look to the left side, there's no problems. Like there's no problems at all. Because again, if this is the lesion eye, there's no problems abducting, looking to the outside. It's always going to be toward the inside because of the muscles that it innervates. Okay. And then another concept, and I put that in red here, is when they're staring straight at you, there's like, it appears to be laterally deviated. So if this is where the eye should be, it's going to be a little off-centered and it's going to be more lateral. It's going to be like it's more abducted. And that's because, like I said, cranial nerve 3 really does adduction, but it has nothing to do with abduction. That's all cranial nerve 6. And again, it's called the abducens nerve, right? So it's ABD is like in the nerve name. So it's kind of pulling it. It's like, hey, like there's nothing opposing me. So that's why even like just looking at it straight on, it's already a little off-centered. And it's because it's like there's nothing like opposing the lateral rectus, which is innervated by 6. And then it talks a little bit like, with in terms of like looking up, it can't do that. Like it also helps with like, if you have the patient look up, it also can't really do that because the superior rectus muscle, which helps look up, is affected. And that's again, remember, if you have a cranial nerve 3 lesion, one of the most common things you see is you have a down and out pupil. And it's like, this is like the best example, like down and out. Well, actually this one, because we're looking straight ahead, and when you're looking straight ahead, you have them, it goes down and out. Okay? And a lot of eye muscles. A lot of eye muscles. And then the next kind of like sticking with the eyes is cranial nerve 4. And this is your trochlear nerve. So again, 1 before the V. This is 4. This is also motor. The only thing cranial nerve 4 does is it innervates the superior oblique eye nerve. So if we go back to this picture, that's this guy. And it's really weird because the superior oblique is like on the bottom, like the outside bottom part of the eye, where you're like, well, it says superior in the name, but it is like, it's down. It's like opposite of what you think. Like the superior oblique is down here, the inferior oblique is up here. And it just has to do with what its function is. Honestly, so the superior oblique helps with intorsion. So intorsion is kind of like, if you think about it, it's like if I want to look from like, actually the best way I describe it, like think about what intorsion is if you're walking downstairs and you want to look at those stairs without moving your head physically, like you want to like look down while your head is straight, that's intorsion. It's like you're looking down, but it's not just like looking down, it's like looking down and medial. That's intorsion. And you need this outside superior oblique muscle to do that. It helps with like go bloop and make it like look inwards. Versus the inferior oblique helps with outwarding. I don't think that's a word, but like that's what cranial nerve 3 does. Okay. So the inferior oblique helps with like looking up and out. Yeah. Up and out. And then your superior oblique helps with down and in. Right. Eye stuff. Super. Ugh. But anyway, so if you have a lesion of this, you can't look down basically. Like you can't look down and like in. So you can't intort. They call this oblique diplopia. They'll never say this in a vignette. It'll say patient is walking down steps and can't do it, or like gets a headache looking down when they're walking down steps. Just think about anything where it's like they're looking at their phone trying to text and they can't do it. Like they go cross-eyed, or they're having difficulties reading when they're reading a book and they go cross-eyed. And then sometimes they'll ask like, how would you expect them to compensate for it? So again, imagine you can't. So like, let's think we have actually, do I have a picture of it? I do. So we'll talk about that. But the compensatory head tilt, sometimes they like are going to be not tricky, but they're trying to see if you know which side of the, like which cranial nerve 4 is lesioned. So a lot of the times you can't tell just because it's like, oh, they get cross-eyed when they look down. That can be either one. So it's a little bit harder than like cranial nerve 3, for example. So what happens when you have like a lesion, let's say of like your right eye, right cranial nerve 4? You can't look down and in with your right eye, right? So what the patient does to kind of, they're basically trying to entort. They're trying to force intorsion by tilting their head to the opposite side. So now if you think about it, my eye on my right side is not moving. I'm going to look straight, but now I'm going to basically twist my head to the left. It's kind of like I'm forcing my eye to intort by doing that. So sometimes they'll say this, patient likes to walk with like their head tilted to the left when they walk downstairs, or like they like to read with their head tilted to the left. That's a right-sided cranial nerve 4 lesion. All right. And then another thing too is we're actually not going to talk about this nerve at all with brainstem lesions, and it's because it is in the brainstem, but just an anatomy thing about cranial nerve 4, it exits the brainstem dorsally. So it exits the brainstem. Usually when we look at brainstem like anatomy, like even if I scroll really fast back to, oh my gosh, I was not prepared for this. Hold on, we're getting there, I think. Right here. We're looking at this ventrally, and it does show the trochlear nerve here, but technically when it leaves the brain, I think they just did this for completeness, it technically leaves the back. So this is a ventral view. They all leave from the front, or like the belly of the brain stems. Trochlear nerve leaves from the back. It leaves dorsally. And that's just like a fun fact. It's like the only cranial nerve that leaves dorsally, but that also means it's really, really, really hard to lesion with like normal brainstem strokes and stuff. So we're actually not going to include cranial nerve 4 when we're doing it's like, you're never going to see it as a symptom with brainstem strokes. Again, just something interesting. But this is what it does. It does intorsion. It's relatively easy to notice on exams, but they're going to ask about the muscles, or they're going to ask about that head tilting, and that's how it gets a little tricky. And then this is just like a summary slide just showing all of the cranial nerves what muscles of the eye that they innervate, and then kind of what its function is. So for example, if this is going to be my left, oh god, yes, this is going to be a left eye, this is going to be a right eye. The medial rectus, this is what does adduction, adduction, so looking towards the nose, which would be like right here. That helps with adduction of both eyes. Your lateral rectus, this is a cranial nerve 6, we haven't gotten there yet, but that helps with a abduction, abduction on both sides. That's cranial nerve 6. And then cranial nerve 4, it does your superior oblique, which technically is like out here, but they're showing it in terms of function. It helps with intorsion, which is down and in. And that's cranial nerve 4. And then everything else is 3. So we have your inferior oblique, which is actually at the top part of the eye, and it helps with looking up. Your superior rectus, which is just straight up looking just vertically upwards. That's also cranial nerve 3. And your inferior rectus, which is just looking down. And that's why this picture, if you kind of go back through all of this with all of the muscles, you're like, oh, that's why they can't look down here. That's why they can't, that's why. And that's what this is supposed to be, like where the eye is supposed to be. And then this is what the patient's eye actually is. So again, this is a left-sided cranial nerve 3 lesion. I might put that at the top before I send this back out. And you can kind of practice with all the fun and being like, okay, this is affecting the medial rectus. This would be affected, this would be if the superior, or this is like if the superior oblique gets affected or whatever, the inferior oblique, not the superior oblique and whatnot. But they will ask about muscles with the eyes because there's so many of them. But I like this picture. It's a nice little summary. All right. So this is a cranial nerve 4 palsy. Again, kind of like the same thing with the cranial nerve 3 that I talked about. This would be on the left side again. And again, it's only the superior oblique gets affected, and it does intorsion. So you're not going to be able to intort at all, basically. And then you're going to have that compensatory head tilt, and it's going to be the opposite side of the lesion. So this is a left-sided lesion, and then you can see she's tilting her head to the right to kind of compensate. She's basically forcing that eye to intort. Okay. Cranial nerve 5, so the V, that's 5. Remember, there's 3 branches of it. They all exit the skull at different areas. It's a massive nerve. It's a trigeminal. And remember, if you remember the 3 branches for tri, tri means 3. And then this is both sensory and motor. Usually when they're doing vignettes and stuff, they'll give you signs of like a global cranial nerve 5 lesion, meaning like they're going to give you signs of all 3 branches being affected, motor and sensory function. So they're just going to give you like everything. So some of the main things you're going to see is the jaw is going to deviate towards the lesion. So your jaw will go whatever side the lesion's on, the jaw is going to move that way. This has to do with one of the nuclei of cranial nerve 5, which we'll talk about. You're going to have difficulty chewing. Cranial nerve 5 innervates the muscles of mastication, and so it'll affect chewing. You'll have a diminished or absent corneal reflex, lacrimation reflex, and jaw jerk reflex. These are reflexes. That's again a very physio-heavy concept. There's like a page in first aid of all the reflexes you should know, and a lot of them they'll give you like, either which branch it is if we're talking about cranial nerve 5, or it's like what's the afferent branch, which is like the sensory, and what's the efferent. Sometimes they're the same. Sometimes the same nerve senses and is the motor. Like this, for example, jaw jerk is probably, it's sensing with V3, and it's the motor function is V3. So it can be both. It can be one, or it can be the other in terms of like afferent and efferent. You'll lose sensation in the anterior 2/3 of the tongue, and you'll lose sensation in the lower 1/3 of the face. Again, it's always ipsilateral because we're talking about cranial nerves, which is always ipsilateral. And then you'll see in brainstem lesions, you'll see these symptoms if you lesion the lateral pons or the medulla. Hopefully it'll make sense when you get there. They love tongue stuff. I don't know why. I think it's just because like there's a lot of cranial nerves that go into both taste and sensation. So I like this picture from Amboss because it shows here's all the ones involved in taste, and they color coded. Here's all the ones involved in sensation. They are different. Some of them. And then the motor is usually just going to be your hypoglossal, which is cranial nerve 12, and that's pretty much its only function. But for taste and sensation, it kind of alternates between 5, 7, 9, and 10. And it color codes it here. So I think I put this picture on like whenever we talk about 5, 7, 9, and 10. But for taste, specifically, cranial nerve 5 does not do anything with taste. Taste is all 7 and 9, and some of 10. And then sensation, that's kind of where the cranial nerve 5 does most of it senses things with the tongue. So it doesn't taste anything. It just has like if you touch your tongue right now, like the bottom, like the what is it, the anterior 2/3. Yeah, yeah. So if you touch the anterior 2/3 of the tongue, meaning like this part of the tongue, like closest to like the outside world, that's the anterior tongue. If you touch it, that's cranial nerve 5. That's relaying that information back to its sensory nuclei. Okay, versus if you taste something, they're like, wow, this tastes great. That has nothing to do with cranial nerve 5. That's actually cranial nerve 7, and that's taste, which I always think is really interesting. It's like two separate nerves. That's like sensing things versus tasting things. But whatever. Okay, so cranial nerve 6 palsy, this is the abducens nerve, and it does abduction. So it is a motor nerve, and it does abduction. So you can't abduct the affected eye. And again, you're also going to get horizontal diplopia, just like cranial nerve 3 palsy, but for a different way now. It's like, remember, if you're looking horizontal diplopia means, again, if you're trying to look in a horizontal plane, like keeping your head straight ahead and you're looking from like just in front of you in a horizontal line, you need abduction and adduction. So you're going to get it with either a cranial nerve 3 palsy or a cranial nerve 6 palsy, because you need 3 for adduction and you need 6 for abduction. Okay. And then when you lesion this, you'll see the symptoms in the medial pons. Here's our favorite amboss picture again with the lesion. So this is a left-sided nerve lesion again. It affects the lateral rectus, which again, the only thing it does is abduction, AB, so looking to the outside. So we're asking the patient to look to so this is right, this is left. We're asking the patient to look for the right. This eye is affected. This eye is adducting, no problem. Looking straight, looking up, looking down, no problem. And like looking out. Here, when you're looking just straight on, notice like just straight on, it's going to be a little bit more adducted, a little bit more going towards where the nose is. Because again, now we have cranial nerve 3 with the medial rectors pulling it a little bit more closer to the nose. This is called estropia. You might see that in vignettes. That's why I put that here. Like they're not going to say, eye is medially deviated at rest when looking ahead. They'll just say like estropia is noticed on like eye exam, and you're like, what the heck is estropia? And it's basically like the medial deviation, like just looking straight ahead. I don't think there's one actually there might be one. I might have just missed it. There might be one. Oh no, there's not. For cranial nerve 3, I didn't know if there was one for, the lateral, deviation at rest, but apparently it's not called anything. But estropia, no idea, is when it's like more medially deviated, just looking straight ahead. Okay. And then if you ask the patient to abduct with the affected eye, again, the affected eye is going to be on the left side. So if we're looking to the outside left, that's where they can't do it. So they can't do it even if they're looking up, looking sideways, or looking down. They cannot abduct. But this eye's fine. And again, a lot of the times they'll give you something like this and be like, what eye is lesioned? And what cranial nerve is lesioned? Is it left? Is it right? And is it 6? Is it 3? Is it 4? Okay. And this doesn't have like a fancy name. Like there's issues abducting with the affected side, just like with 3. If you have issues adducting with the affected eye, that's called internuclear ophthalmoplegia. There's nothing like that with cranial nerve 6. It doesn't get a name. Okay, so I think that's all but there's estropia, but all right. All right, 7. So cranial nerve 7 palsy. Cranial nerve 7 is the facial nerve. It's sensory and motor. It's going to so cranial nerve 7 is really strange. It's so I have a lot of pictures to kind of help demonstrate this. This did not make sense to me at all first year. I'm not gonna lie. I just was like, all right, cool, we'll memorize it. So I'm really gonna try to explain it really nicely so you can be like, no, I get it. I understand it. So remember that these cranial nerves, right? So they have upper motor neurons up in like the motor cortex, right? Because then they follow the cortical bulbar tract and then they go through, the internal capsule, whatever, and then they fan out as, contralateral, ipsilateral cranial nerves. Like that's kind of just overall what happens with cranial nerves. Cranial nerve 7, it has a really weird, you can call it like a decussation pattern. It has a really weird one in that it splits itself and then it innervates different parts of the face. So it is the facial nerve. So it does do sensory and motor functions of the face. But if you lesion different parts of cranial nerve 7, and usually it's like before it decussates, or remember decussates means like crosses midline. If you lesion it before it crosses, you're going to see a set of symptoms. And if you lesion it after it crosses, you're going to see a different set of symptoms with the face. All right. So If you have a central lesion, meaning it's going to be before the decussation, so like way up here, think of this as like an upper motor neuron lesion, even though, again, I know these are cranial nerves in general act more like lower motor neurons. Like that's how you can kind of think about them. Just for cranial nerve 7, you can kind of think of a central cranial nerve 7 lesion kind of acts like an upper motor neuron lesion, in that if you lesion it before it crosses, so if you lesion it, again, just like if you lesion the corticospinal tract or whatever, before it crosses, you're going to see contralateral signs. So again, this is like what you just said, cranial nerves are ipsilateral. I did say that. But a central lesion is going to be before, and again, this is the only cranial nerve that you have to remember this for. You're hitting it before it crosses, so it's going to do contralateral, okay? Because again, it didn't cross yet. So if I hit it up in the right side, it's going out to the left side of my face. But since I hit it all the way up, it's all the way up here, it didn't cross yet. I'm going to hit it up here on the right side, and I'm going to have the symptoms down here on the left side. To make it even more confusing, so we already have the one confusion thing, is that we have a contralateral cranial nerve sign, which you're like, that shouldn't exist. The other thing too is when it splits, specifically cranial nerve 7, some of the fibers innervate just the upper face. So if this is a face, some of the fibers, and again, it crosses the midline, right? So let's say we're up here on the right side. It comes down. Okay, it's coming down. It's going to cross. Some of them are going to go over here and innervate the top, but then other ones are going to go over here and innervate the bottom. And so you can, this is just like a general drawing of it. And now it's basically saying like, I'll show you a picture that might actually help, but just keep in mind it branches and it crosses, okay? So some of them only innervate the bottom half of the face, some of them innervate only the top half of the face, and then some of them cross and stay ipsilateral. So some of them are going to cross and stay ipsilateral, and then others are going to just cross and not have ipsilateral. I'll show a photo. Actually, let me just show a photo now. I'm just going to show a photo now. So this, and again, I know this is there's really not a good picture for this. So let's just start with this. Let's not look at lesions. All right, let's not look at lesions. Let's just start here. So this is cranial nerve 7. And I appreciate what they were trying to do. I do appreciate it. They basically were, and I tried to help. So they basically tried to show like, here is, if I have to look at the brain, this would be the right side. And then this is the left side. So they basically tried to show, so if I look at the lower face, let's break the face in half. The lower face is only supplied, and that's what I wrote here, the lower face is only supplied by contralateral fibers. All right, so again, remember they tried to color code. They tried, and again, you have cranial nerves on both sides, remember, because there's ipsilateral on both sides. So you have a cranial nerve on the left, you have a cranial nerve 7 on the left, a cranial nerve 7 on the right. So we're talking about cranial nerve 7 on the right. Cranial nerve 7 on the right, it's going to cross, that's this yellow color. So that's going to cross, right? And it's going to go over here and innervate the lower left side. This light blue, so this is now your cranial nerve 7 on the left, it's going to cross and innervate the lower right side. Okay? Okay. So the lower face is only innervated by contralateral cranial nerve. So bottom left is only coming from the right cranial nerve. Again, it's really weird. It's like the only cranial nerve that does this and like crosses like this. And then the right lower face is going to be basically innervated by the left cranial nerve 7. Super weird, very odd. And then the upper face is just like normal. Okay, so it's just like normal. So it's going to be ipsilateral on both sides, but there's also going to be a contralateral component as well. So people a lot of times will like draw this as like, upper face is like contralateral and ipsilateral. And then your bottom face is only contralateral. And if you remember, I actually very quickly skimmed through the slide because I knew it wasn't going to make sense yet. This one back here, you can kind of see when it talks about cranial nerve 7 here, it's saying like cranial nerve 7 to the upper face is ipsilateral fibers and contralateral fibers, versus cranial nerve 7 to the lower face is contralateral only. Okay? Because all the nerves, they're going to fan out. Like all the cranial nerves, it's going to be one on the left, one on the right. It's just the lower face. Just the lower face is only, there's no ipsilateral innervation to the lower face. That's like another way you can kind of think about it. No ipsilateral, it's only contralateral. All right. So again, I think this is a really confusing way they drew it. I understand what they're trying to do. They're trying to show color coding, but you can just think of it as like there's contralateral and ipsilateral innervation to the upper face and only contralateral to the lower face. You're like, cool, well, why does that matter? Because if you have, they call it Bell's palsy. So Bell's palsy is when you just have drooping of like the lower face, like that's it. Like you can raise your eyebrows, you can do all sorts of stuff with your upper face, you can like make wrinkles with your forehead. It's just you have face droop on the lower half of your face, and you're like, what is that? And that can be like a sign of like a cranial nerve 7 palsy on the opposite side, and they'll ask usually like what is this an example of or whatever. So if we look here, this is going to be on the right side. If I have a lesion before cranial nerve 7 decussates or crosses over, I'm only going to see palsy here. This is Bell's palsy. Okay, so it's only going to be the lower face is going to be affected on the opposite side. Versus if I lesion right cranial nerve 7 after it crosses, so after the decussation, it's going to be that whole side. It's going to be the ipsilateral upper and lower face like after it crosses over. This one, like after the decussation, this is exactly what happens with all cranial nerves. It's because again, cranial nerves act like these lower motor neuron lesions. If you're lesioning right like at the site of like, where the cranial nerve acts, that's why you see these ipsilateral signs of cranial nerves. The only weird thing is this one, and this is the only thing you have to remember is like if you lesion it up in the head, like up before it crosses, it's like not down in the brainstem yet, it's up in the head, like where those upper motor neuron fibers are. You're going to see contralateral lower face only, and the amount of times this comes up in questions is insane. Okay, so I don't know if I did that helpful of a job with this, but I just and now we're going to kind of walk back through what I wrote here, but hopefully that was a little bit more helpful. But again, if you lesion it up in the head, you're going to see contralateral lower face only. That's called Bell's palsy. So when you see this, and again, Bell's palsy, it's not the whole side, it's usually just the lower half of the contralateral face. A peripheral lesion, this is after the decussation. This is literally like all cranial nerve, all other cranial nerve lesions, is you're going to see complete, like like facial nerve innervates the whole face. Cool. You're going to see ipsilateral, that whole face is going to be out. And it's going to be that side cranial nerve is affected. All right, cool. Hopefully that helps. So complete paralysis versus like a partial paralysis. You'll also see a loss of taste in the anterior 2/3 of the tongue, because remember, that's what it does. And with brainstem stuff, you'll see it in the medial and lateral pons. We destroyed this slide, but hopefully that makes sense a little bit. Just remember, opposite, the bottom half of the face is weird. This part, so the left side of the face is innervated by the contralateral cranial nerve 7. The upper half of the face is contralateral and ipsilateral. So it's like a lot of people ask, well, if it's contralateral and ipsilateral, like if you take out this green section, like, right, if you take out green here, why is the upper face fine in this instance? Because remember, it has these fibers from the ipsilateral cranial nerve 7. So it can kind of take over. You won't see a defect at all. It's almost like a backup that it has contralateral and ipsilateral. They think it's like an evolution thing. Like facial expressions are really important. So they think that it was this like conserved mechanism over time that it's like, oh, we have like a backup for facial stuff. So even if you take out one, like you won't be able to see it. But for whatever reason, the bottom half of the face wasn't as important as the top half of the face, I guess. Just the mouth. They didn't really care about the mouth evolutionarily. It just got one side, just got the contralateral side innervating it. And then here's this picture again. So now we're talking about the facial nerve, which is in yellow, has nothing to do with sensation. And it's pretty much what cranial nerve 5 does for sensation, the anterior 2/3 of the tongue, cranial nerve 7 does for taste. So it does the anterior 2/3 of the tongue. Okay, so don't get confused with that. That will also probably be like an anatomy question they ask you. All right, 7's done. The hard one is done. We made it. So cranial nerve 8. Remember, there is like that motor component of it. There is a motor nuclei for it, but it is definitely a sensory. Like the most important function of cranial nerve 8 is sensation. So the main one is hearing. So there's 2 nuclei. Again, we're going to talk about the nuclei. The first one is straight up hearing. So the cochlear nucleus, that's what allows you to hear. If you lesion it, you'll get sensory neural hearing loss. Like you'll literally lose hearing in that ear. Versus the vestibular nucleus, this is what helps you with balancing your head. And so if you lesion it, you'll get vertigo and whatnot. You'll see horizontal nystagmus, which is another eye thing, but this is, that's something later. And then you'll see the brainstem lesions in the lateral pons in the medulla. Cranial nerve 9 palsy is glossopharyngeal. We've talked about the glossopharyngeal before. Remember, so it was important with your baroreceptor reflex, throwback to cardio. So it does have that effect. It's the afferent for, I think it's the carotid body's baroreceptors. If you lesion it though, in terms of like neuro stuff, you'll see a loss of ipsilateral gag reflex. So the gag reflex is 9 and 10. So cranial nerve 9 and cranial nerve 10. 9 senses, senses that something is touching your uvula, basically. That's cranial nerve 9. And then the actual gag, like the actual like effect of touching the uvula, that gagging motion, that's cranial nerve 10 mediated. That's the efferent reflex part of it, if that makes sense. But gag reflex is going to be the afferent branch of the, again, ipsilateral, because we're talking about cranial nerves, the ipsilateral part of the gag reflex. And then you're also going to lose taste in the ipsilateral posterior 1/3 of the tongue. And then you'll see this with lateral medullary brainstem lesions, which we'll talk about. But here is cranial nerve 9 in green. So it is involved with sensation. So the posterior 1/3 of the tongue, again, they break it up like posterior, anterior. So it does sensation, and it also does the back, sensation, taste in the back of the tongue. And people are like, well, what about the vagus nerve? Vagus nerve, usually they'll say like, oh, it's like soft palate. So like soft palate, sensation, and taste, which is not really the tongue. So on this image, when they're talking about the tongue, they're pretty much just like talking about like this, honestly. Like this is in terms of like how they break it up, like anterior 2/3, posterior 1/3, whatever. That's kind of how they break it up. All right. And then cranial nerve 10 palsy, this is your vagus nerve. You guys, how many times have we talked about the vagus nerve so thus far in the body system? So lots of stuff would happen, but in terms of brain stuff, like neuro stuff, you'll see paralysis of the ipsilateral soft palate. So it does innervate it's really big on innervating the soft palate. Deviation of the uvula away from the lesion. This is really important. A lot of the times they'll like give you a symptom like this, like, oh, the uvula deviates to the left. And you're like, oh, what side is affected? Like, you're like, oh, which cranial nerve is that? Is it the left or is it the right? So basically what they're saying is if you have a cranial nerve 10 lesion on the left, you'll see paralysis of the left soft palate, but then you'll see the uvula. If you look at the uvula in the back of the throat, it'll deviate to the right. It deviates away from the lesion. And the way people get kind of confused with that, but remember the uvula hangs? Oh my gosh, I'm sorry. That's the best I can do with the uvula. So let's say this is the right side, this is the left side. If you lesion cranial nerve 10 on the left, this is going to deviate this way. And the reason they think that and how you can kind of like think about this so you're not memorizing it is the uvula is hanging. So there are these fibers. Think about anything that hangs. You need to like hang it from like the ceiling basically. So there's like, you can think of it as like there's these ropes. Like there's ropes hanging it on both sides. If you lesion one of these ropes, only this rope on the right side is pulling it. So that's why it deviates the opposite direction. Hopefully that helps, but it's because it's hanging and that's why it goes the opposite direction. You're like, why does it go the opposite direction? Because I think people think it's like, is it getting pushed? Like what's going on? It's because it hangs. So it gets pulled by basically like the right side in cranial nerve 10. You see dysphagia, so you're gonna have trouble swallowing, loss of gag reflex. This is the efferent part of the gag reflex. And then you'll see hoarseness because of that good old recurrent laryngeal branch, that left recurrent laryngeal. So if you do lesion cranial nerve 10, you will see hoarseness. Here's your vagus nerve. So again, it does soft palate, sensation, and taste. I don't really know if the soft palate is involved in taste, but I mean, it's going to be the same in both. It's going to be the soft palate. All right, and then cranial nerve 11, almost done. This is your spinal accessory nerve. So this is a motor cranial nerve. So it's going to be involved just with like motor functions. Technically, it's not really a cranial nerve. And Dr. White says this too. He's like, basically, it's just like, it like was named wrong basically, but it's still a cranial nerve. So we're going to call it that. It innervates your trapezius muscle, so your traps. So if you get a lesion, again, that's why it's weird, like this is a cranial nerve because the symptom is like a muscular thing. You're like, that's really odd, like a major muscle gets affected. But regardless, the lesion is going to lead to ipsilateral, again, cranial nerve, ipsilateral shoulder dropping, because again, your traps hold like your shoulders up. Like it's one of the muscles that holds the shoulders up. So what you can do, or like what they'll say in vignettes, is like you ask the patient to shrug the shoulders, and then one side's not going to shrug. So like this side didn't shrug, I would have a left-sided cranial nerve 11 lesion. It also innervates your SCM, so your sternocleidomastoid. It partially innervates the sternocleidomastoid, and remember the sternocleidomastoid helps you like look to the opposite direction. So my right sternocleidomastoid helps me look over to the left, and vice versa. So they can also talk about this. There's weakness turning your head to the contralateral side. And then technically it's not located in the brainstem. I know it's usually drawn in brainstem pictures, like if you look at the medulla, like on that one slide, it'll be in there. Technically it's not. And if you had like anatomy with dissection, I remember Dr. Garcia would point it out. He's like, look, this is the spinal accessory nerve. I'm like, that's nowhere near the brain. Like that's not even anywhere near the brainstem. He's like, yeah, it's not really a cranial nerve. Like, okay. But that's what you don't really see cranial nerve 11 symptoms at all in brainstem lesions. Like they're just not there. So like 4 is not there. 11's not really there, and then 1 and 2 are never there. So we only have like 8 cranial nerves to work with brainstem lesions. All right, which we'll get to, and then cranial nerve 12. So this is your hypoglossal nerve, and it kind of tells you hypoglossal. You're like, okay, glossal tongue, and this is motor function of the tongue. So the tongue has tons of innervation. There's just tons of things happening with the tongue, and really the only thing it does is move the tongue. So if you lesion it, again, it's going to be ipsilateral, because again, we have 2 of each. You're going to see atrophy on the side of the lesion. So if the patient sticks their tongue out, half the tongue is literally going to be lesioned. And then if you have them stick their tongue out, it's going to deviate. So it's kind of like the uvula, but it's opposite. It's going to deviate towards the side of the lesion. So now people are like, well, how do I remember that? Like the tongue is not hanging. So that's like one way you can kind of be like, all right, that's a difference from the uvula. But everyone always remembers lick your wounds. So if I have a cranial nerve lesion on the left, and I have the patient left and right, and I have the patient stick their tongue out, as soon as they stick it out, it's gonna move towards the left side. And that's a lick your wounds kind of thing. I'm gonna lick or move the tongue closest to the side of the lesion, which is gonna be on the left side. All right, and this is an example of now it's like the right side is pushing it, and that's why it's moving that way, versus if it's hanging, it's pulling it, and that's why it goes the opposite direction. Hopefully that helps a little bit. And then the hypoglossal really just does motor function of pretty much the entire tongue, the entire thing. All right, cool. And then I have some anatomy, and then we're going to end with our tic-tac-toe method and then call it a day. So the brainstem, so sometimes they will show you cross-sections of the brainstem and then have you identify structures. And I did find questions on Amboss, and I did put them in here. So you can kind of see, I did get some questions like this on boards where it's like I had to locate the actual like nucleus or cranial nerve in the brainstem. So kind of like if you look at it, this is, again, we talked about this last time, but this is if I pulled out the brainstem from where it looks in the brain. Remember, we have the midbrain, we have the pons, and then we have the medulla. And again, remember the 4, 4, and 4. This is the blood supply to the brainstem, and we're going to talk about all of these, but the entire midbrain is supplied by the PCA. And if you're like, nice, that's also a cerebral artery. So it's one of the 3 main cerebral arteries. So remember your ACA, MCA, PCA. PCA supplies, remember, the occipital lobe, pretty much the entire sight center, and it does a lot of other like random parts of other lobes. It also supplies the entire midbrain. Medial midbrain and lateral midbrain, just the whole thing. So I drew this box basically over where the midbrain is, and you can see here's the PCA. Remember, the circle of Willis is going to be up higher, and remember I was like, it's like the head of the alien, and then the body of the alien is going to be the brainstem. We're talking about the body of the alien today, but the arms of our little alien guy, that's the PCA. And that's like going to still be involved with brainstem stuff. It's kind of like bridging cerebrum to the brainstem. So that's what the midbrain is innervated by, posterior cerebral artery. And then here is kind of like your, so this is like little terms, like how you can kind of identify it if they give you a ventral view or a dorsal view. So if they give you a ventral view, remember that's like the front, dorsal view is the back. So this is normally when you're looking at brainstem anatomy and like brainstem anything, usually they show you a ventral view. And kind of how you can identify where the midbrain is basically like basically what I have here. Like look for the cerebral peduncles, which are going to be like these, and I have here, like I circled it. It's just going to be like these two little like grooves here. Those are your cerebral peduncles. And then the whole midbrain is outlined, and notice that it includes cranial nerve 3, cranial nerve 4. Another thing so the ventral view of the midbrain is also called the tegmentum. I don't know why, it's really weird, but like the ventral view is the tegmentum. The dorsal view of the midbrain is called the tectum. And it's just, they like to be really confusing and just give you more terms to memorize. This is just two of those terms. But I do mention it because sometimes they'll say like supratectal or, the ventral tegmentum, or like they'll use those words. They're talking about they're talking about the midbrain when they mention it, when they use like tectum and tegmentum. All right. And then if you look on the dorsal view, so the back of the midbrain, they like look for the two mounds and hills, basically. So it's like look for these, they call them little hills and mounds and whatever that's in the midbrain. But you can also just like look for the topmost part of the brainstem, and you're like, cool, that's probably midbrain. That's not the big bulge. That's the midbrain. And then again, remember, like I said, cranial nerve 4 technically doesn't exit, and it's always drawn on the ventral view, but technically it doesn't exit here. It exits on the dorsal view, and that's what this is showing here. It is the only cranial nerve, and that's what this is, that exits dorsally. So that's why it's very, very, very hard to lesion. You likely will like never see dorsal, like you'll never see cranial nerve 4 lesions in brainstem lesion questions, if that makes sense. Like you'll never see an inability to intort because they had like a PCA stroke or something like that. You know what I mean? Like, because again, the PCA supplies the midbrain, so you're going to take out these cranial nerves, but like 4 never gets affected. Okay, and that's why, because it's exiting on basically the opposite side. All right. This is going to be all of the nuclei. And remember I said like, there are nuclei involved with all these cranial nerves. And again, each nuclei kind of just like correlates, it matches up to a function, right? So for example, here is the midbrain in general. So if you think of this as like, this is the midbrain and you split it into like half areas, like I tried to match it up with Dr. White. So this is only half the midbrain. Like, let's say this is only the midbrain on the left side. I'm just like the midbrain on the right side is like not on this image. And then you break it up, motor and sensory, medial and lateral. The medial portion is always going to be your motor portion. That's why all the the cranial nerves that are in the middle are in the medial portions. Yes, I said that right, I think. And then all the sensory nuclei and cranial nerves are going to be in the lateral portions. So motor and medial kind of line up, and I always like confuse the two accidentally. And then sensory and lateral always line up. So if you have sensory cranial nerves, they're likely going to be located on the lateral side. They don't line up perfectly, but that's why too, like motor medial like lines up really nicely. So if you know which ones are located in the medial part of the midbrain, of the entire brainstem, likely it'll have like a motor component if it's located like in the medial portion. Just like a fun thing. And then here are all of the nuclei that are like located here. I also separated rostral versus caudal. This is something that Dr. White does a lot. And like I said, Dr. White is writing some of your exam questions. He does every year. So I do think it's worth it to understand the rostral, like which like if you had to break up the midbrain into rostral components and caudal components, knowing what's there basically. And I spent a lot of time trying to like draw it out to make it make sense, but rostral just means like the upper portion of it, and then caudal is like the lower portion of the midbrain. So we're still talking about the midbrain, but now it's like the upper portion of the lower portion. So here is, for example, cranial nerve 3. This is the nuclei, and remember it sends out its little tracts and it goes and does, goes to the eyes, for example, because cranial nerve 3 goes to the eyes. So this is the nuclei of it, and remember that it always goes with Edinger-Westphal, always. Edinger-Westphal is the parasympathetic like tract that just goes with cranial nerve 3. So I have the function here. This is just like a little summary for you guys for studying purposes, but cranial nerve 3, it adducts, it elevates the eye, it raises the eyelid. When you're studying, you can throw in like what specific muscles it innervates, like your medial rectus, your superior rectus, blah, blah, blah. And then the Edinger-Westphal is going to do your pupillary constrictions, and it's going to do your accommodation reflex. That's what Edinger-Westphal is involved with. The caudal portion of the motor region of the brainstem is going to be cranial nerve 4, and this is going to do your intorsion. So because it innervates your superior oblique. And then over here on the sensory portion, we have our mesencephalic nucleus of 5, which you're like, hold on. Cranial nerve 5 is in the pons, 100% correct. But something you're going to see is that cranial nerve 5 is the only, because again, remember it's a massive nerve, massive. Its nuclei span the entire brainstem. It's going to be in the midbrain, it's going to be in the pons, it's going to be in the medulla. Primarily, cranial nerve 5, the nerve itself, is in the pons. Like that's where it is, and that's where it like exits. But the nuclei, again, it has 3 different nuclei because it has 3 different branches. Actually, I think it even has more nuclei. Cranial nerve 5 has tons of nuclei. There's always going to be some sort of cranial nerve 5 nuclei in every single brainstem section. Every single one. So here is just one of them, because of course. And that's actually how you can tell that it is cranial nerve 5 if it's in every single cross section of the brainstem. So here's one of them, the mesencephalic nucleus of 5. Mesencephalic does jaw. It's your jaw jerk reflex. So this does proprioception of the jaw, basically. And it spans, again, the whole midbrain. So it's rostral and caudal. And again, try to match it up to how Dr. White did it. I think I don't know if you guys have gotten to his cranial nerve lecture yet or like went this deep. I think this is extremely confusing how he explains it. I needed to draw it out and kind of just like make sense of it in my brain. So that but I put the Dr. White picture so you can see like what I'm trying to do with my images. All right, so this is the midbrain. My rules of thumb, so if you ever have to identify a cross-section of any of these brainstem regions, all midbrain cross-sections, so all of them, are going to have your cerebral aqueduct, which we talked about last time. They're going to have some sort of descending long tract, so corticospinal tract, corticobulbar tract. They'll have the spinothalamic tract, which is your ascending, spinal cord sensory tract. Your medial lemniscus, which also comes from the spinal cord, it's an ascending tract, and then your cerebral peduncles. So those are all midbrain cross-sections. Here is from Anki, and again, we're not doing this right now because it would take way too long, but I basically went through and labeled so again, if they showed you this on an exam, or just like if you're trying to figure out like what part of the brainstem am I in by seeing this image, it's kind of like how you can identify that I'm in not only the midbrain, but I'm in the rostral. I'm in like the way top part of the midbrain. And again, the kind of how you do this is look for like that superior colliculus. Look for, cranial nerve 3 is going to be higher than 4. So if you're only really seeing cranial nerve 3 and not 4, you're a little bit higher up. Versus the caudal midbrain, which now you're a little bit lower down because you're at the bottom part. Notice here's cranial nerve 4. Notice how it literally crosses. This is them, like this picture, trying to show exiting dorsally. That's just what they're trying to show here. It doesn't actually do it. It doesn't actually do that, but they're just trying to show that it doesn't really exit here. It kind of like wraps around and leaves through the back. It's just a 2D image for a 3D concept. All right, so this is again for you, and you can kind of like use this slide to kind of like try and identify everything on here. And yeah, but it's a lot of anatomy. There's a neuroanatomy deck on Anki, and that's again where a lot of these came from. And I don't know I don't think they're going to straight up ask you like question, like literally show you this image and be like label this entire thing. But I think it really helped learning what structures were located where in the brainstem by doing it like this. Okay. And then I pulled these from Dr. White. I'm not going to go through them right now, but if you can kind of like, well, I guess I just gave you guys the answer. But if you look at this and then you're like, all right, is this rostral or caudal? This looked more like the caudal. And then kind of go through, label it. You might see like a question, like maybe one like this on your exam. Definitely on boards. They do ask brainstem cross sections on boards, which is why I kind of am going through it right now. Because I think this stuff's really, it's like, I'm not a neurosurgeon, I don't know. But this is more of the rostral brainstem. You can see how it looks different from the caudal, or the brainstem, the midbrain. And I knew it was midbrain. Again, here's my cerebral aqueduct. I will always have a cerebral aqueduct, rostral or caudal. All right, pons. So the pons is going to be, now this section, it's going to be the big bulge. There's 2 arteries that innervate the pons. One supplies the pons medially, one supplies the pons laterally. So the medial pons is innervated by the basilar artery, which is right here in the middle. So it's the body of our alien dude. And then the anterior inferior cerebellar artery, or ICA, I call it ICA, innervates the lateral the lateral portion of the pons, basically. And it is really confusing because cerebellar is in the name. And it does innervate the cerebellum, it does, but it also innervates the lateral portion of the pons. So just ICA. I do ICA. And then for the pons, really easily from the ventral side, look for the bulge. I should have taken out tegmentum and tectum. I apologize. This is just midbrain terminology. But regardless, here's the pons. Here's all the cranial nerves that are in the pons, and you can kind of like always find 5, and then you can try and find the rest. But again, if you do the cross section, I only wanted to point out that the trochlear is in the midbrain, so don't get confused with me highlighting it just for showing the pons. But there's also these cerebellar peduncles located here. This is involved with the tic-tac-toe method to see that there are cerebellar tracts in the pons. All right, so just wanted to point that out. But pretty much all the cranial nerves you're going to notice on the ventral side. Here are kind of the same drawing. So it's like the half of the pons and then medial and lateral, motor sensory, kind of the same thing. So remember, the medial vascular territory, this is the basilar artery. And then the lateral vascular territory is going to be the ICA. The anterior inferior cerebellar artery. And then I have all the nuclei. So of course we have the most of cranial nerve 5 because cranial nerve 5 is like everywhere. So we have the motor nucleus of 5. So this is where the motor tracks from 5 kind of like start. This is the one that's supplying the muscles of mastication. Here are the muscles of mastication. I believe I bolded this because they asked this on your exam. That's the only thing I can think of why I highlighted this. But these are just good to know. Like these are the 4 muscles of mastication. Your sensory nucleus of 5 is going to be on the sensory side, the lateral side, right? And that's going to do sensory information of the face. The sensory nucleus of 5, again, it's really just, and it's confusing because it's cranial nerve 5, but we're getting facial sensation. So don't get confused because it's not the facial nerve. It's sensory nucleus of 5, facial sensation. And in the same kind of vein, the spinal trigeminal nucleus of 5, this is like the spinothalamic tract of the face. So it's pain and temperature, but now of the face, it goes to cranial nerve 5. It's a cranial nerve 5 sensory nucleus. Okay. And then again, I did rostral caudal again. So just kind of like, just to keep an eye out for that information. Like, for example, if you were like, I have no idea, 5 is in like, well, 5 is everywhere, but like 6, for example, 6 and 7, that comes after 5. So I would say it's going to be lowered down. So that's going to be more caudal. Just like with 3 and 4 is lowered down because it comes after 3. So it tends to follow that, not always, but like if you're ever stuck and like you have a Dr. White question where it asks rostral versus caudal, usually the ones like in that group of 4 that are lower, like that are later, are going to be lower because it does kind of follow that nice like hierarchical like numbering. Okay, so we did the rostral. So now caudal. So we did spinal trigeminal. Now back to the motor side. Cranial nerve 6, so the abducens nucleus. Remember, this is a motor nerve because it's eye movement, but it's on like the outside, right? It's abduction. It's the lateral rectus. We already talked about that. It comes from this nucleus. And then there's 2 nuclei for cranial nerve 7. One is your motor nucleus of 7. It does the motor supply of facial expression, so it lets you actually make facial expressions. And then you also have a oh no, it's not 7, sorry, it's 8. The superior salivatory nucleus, this is innervation of the salivary glands, and it happens to be here in the pons. Fun fact. And I'll show you also when we do the cross section where that is, but here's your rules of thumb for the pons. All pons cross sections will have the 4th ventricle. So just like all midbrain cross sections are going to have your cerebral aqueduct, all pons cross sections will have a 4th ventricle. And then you'll always see the long tracts. So corticospinal, spinothalamic, medial lemniscus. You'll see some transverse pontine fibers. These are just really easy to point out, like on cross sections. Any trigeminal nucleus, literally any. And this is, I should have put this for all of the brainstem cross sections because like cranial nerve 5 is in every single cross section. But it's like just any of the trigeminal nuclei will be here. And then the medial longitudinal fasciculus will also be located here. And this is involved with like coordination of sight and stuff like that. That's like a later session. But your rostral pons, here's your 4th ventricle, so you know you're there. Remember that rostral pons is going to be laterally supplied by ICA, medially supplied by basilar artery. And then Since we're higher up, it's pretty much just going to be 5, like no 6, no 7 yet, or even 8, anything to do with 8. Here's all the tracks that are usually here: spinothalamic, medial lemniscus, your corticospinal, corticobulbar, blah, blah, blah. The transverse pontine fibers are just like, again, like I said, just easy to see on like pons cross sections. And then here's your MLF in the middle, medial longitudinal fasciculus is going to be in the middle. And then you have like your two, like just any of the cranial nerve 5 nuclei, they're here. Little bit lower down, here's 6 and 7. Here's where 6 and 7 come in. And 6 and 7 is, if I were to pick a cross section for someone to like know, I would pick the caudal pons. And it's because of this weird thing that 7 does with 6. So here's your abducens nucleus, right? So this is your cranial nerve 6 nucleus. Here's your facial nucleus, or like the facial nucleus, cranial nerve 7 nucleus in blue. Notice how before cranial nerve 7 leaves, it wraps around cranial nerve 6. It's really weird. So 6 and 7 wrap around. This does have some sort of implications for your brainstem lesions in a little bit. You actually can't use symptoms from 7 to help you identify where you are. And it's because 6 is so close to it. But we'll talk about it. I think I zoom in a little bit, or I think I talk about it in a second. But is this rostral or caudal? This is going to be rostral. The fourth ventricle is massive. And is this rostral or caudal? This is caudal, but the fourth ventricle is massive. So I know we're in the pons here. Here's another picture, I think it's from Dr. White, showing again in the caudal pons. And I don't think you can really see it here, honestly. I otherwise I would have pointed it out. I don't think this is a great cross-section, but I think all these cross-sections are horrible. But I guess what he's trying to show is that here's the abducens nucleus, so cranial nerve 6, and then here's 7, how it literally, the axons wrap around cranial nerve 6, which is really odd. It's like the only one that does that. But if you see that, you know that you're in the caudal pons. All right, and then lastly, the medulla. So this is the last part. It has innervations from the anterior spinal artery, or ASA, in the medial portion of it. So that's this guy right in the middle. And then pica, or PICA, posterior inferior cerebellar artery. So again, just like ICA, it has cerebellar in the name, but it supplies the lateral medulla. But you will see cerebellar symptoms in different types of strokes. That's why it's like good to know the full name of it, to be like, okay, yeah, cerebellar. There's going to be cerebellar signs. Again, here it is here. So here's the medulla. It has 9, 10, 11, and 12 ventrally, not tegmentum and tectum. And then dorsally, no cranial nerves are here. And it's just going to be the bottom part of the brainstem. All right, lots of nuclei, lots of really like long nuclei that span here because it's 9, 10, 11, and 12. So 9 and 10 have a lot of nuclei because they do a lot of stuff in the body. So if we look medially, that's going to be like your ASA territory. So the ASA supplies this area. There's a bunch of nuclei. So the inferior salivatory nucleus, this is kind of like the nucleus for like 9, 10. I think 7 goes to it. Like a bunch of cranial nerves come from this nucleus. And actually, what I wanted to show, I think I'll show it to you on the medulla cross section. I want to show you what I mean by this. Like, what does it mean that cranial nerve 7, 9, and 10 come from this nucleus? It's basically like when it sends out these branches, it sends out like a branch for 7, 1 for 9, 1 for 10. Like, so that's what it means when it's like a lot of these cranial nerves can potentially share a nucleus. It can send out axons that are like from multiple cranial nerves. Nucleus ambiguous is 9 and 10, so it's going to do kind of the same thing. It's going to send branches for 9, branches for 10. Dorsal motor, and I put what all the functions are here so you can kind of like reason through what all of these things are. The dorsal motor nucleus of 10, this does motor functions of 10, so that's nice. And that's going to be like normal vagal nerve stuff. Hypoglossal, this is your motor for the tongue, which we talked about. Nucleus tractus solitarius. Remember, I was like back in cardio. I was like, hey, this is going to come back in neuro. Here we are. So as you guys know, this is going to do baroreceptors. So the NTS, nucleus tractus solitarius, does baroreceptor reflex information. So it gets sent afferent stuff from the cranial nerve 9, and then it sends it out with cranial nerve 10 over here on the motor side. Because remember, anything afferent goes through sensory, and then when it sends out efferent stuff, that's usually motor. So something like, again, baroreceptors, afferent goes in here, and then it kind of figures out what it wants to do, and it sends out whatever the efferent is, but usually from like the motor side, if that makes sense. Hopefully it does. And then also the NTS receives taste sensation. And again, this is another example where it's 7, 9, and 10. So like all taste sensation, 7, 9, and 10 go to the nucleus tractus solitarius. This is your vestibular nuclei. So the vestibular nuclei is going to do for cranial nerve 8. So it's going to maintain equilibrium. This keeps you on balance, basically. And then you have your cochlear nuclei, or cochlear nucleus, that's hearing for cranial nerve 8. Again, I tried to color code as best as possible. And then here is your spinal trigeminal of 5. Look, we still have 5. We're all the way down the medulla, and we still have cranial nerve 5. But it's going to receive facial pain and temperature. It's just that same one that was in the pons. It just goes all the way down. It just extends all the way down. But just don't get confused, because we are talking about facial stuff, but we're talking about the nucleus for cranial nerve 5, because it does have a really big facial component. I, again, always think of the spinal trigeminal nucleus of 5 as the spinal thalamic tract. It's basically like the equivalent of the spinal thalamic tract, but for cranial nerve 5 in the face. All right, rules of thumb. This is like a little bit harder because there's nothing really like that pinpoints that this is the medulla. But you can thank the absence of the fourth ventricle and the absence of the cerebral aqueduct, because everything else is going to be there. And then you'll see just like specific cranial nerve nuclei. There's just a lot of cranial nerve nuclei here, as you can see here. But I really did like this picture, and I wanted to show you, like, this is kind of what I meant. So for example, the nucleus solitarius, so the NTS, see how it has this one branch for it has like this one branch here. It has another, and then, sorry, hold on. I explained that wrong. Cranial nerve 10. So here's cranial nerve 10. It gets a branch from the nucleus solitarius. So the NTS, it gets a branch from the dorsal motor nucleus of 10, and it has a branch from the nucleus ambiguus here. So all of these branches from all these nuclei come together, make up cranial nerve 10. Just like cranial nerve 8, it's going to have a cochlear nuclear branch and a vestibular nuclear branch, because it's made up of both of those things. It does vestibular stuff, like with balance, and it does hearing. And that together makes up cranial nerve 8. Cranial nerve 9, same thing. It has a branch from the nucleus solitarius. Where is it? Nucleus solitarius. And it has a branch from your nucleus ambiguus here. And boom, there's your cranial nerve 9. And then here's your hypoglossal. Here's 12. 12 really only does, tongue stuff, like tongue motor. But yeah, so I also think the medulla looks like a butterfly. So that's, how I can kind of tell them in the medulla. But that's the rostral medulla. The caudal medulla starts to kind of look like a spinal cord cross section. So we're starting to get a little bit spinal cordy by the time we're in the caudal medulla. And you can even see there's some tracks here that are coming up from the spinal cord. So not as many nucleus, but of course there's going to be a cranial nerve 5 nucleus somewhere in there. And you'll start seeing a lot of decussations, because remember, it's like, oh, there's a pyramidal decussation of this tract or whatever. They're talking about there's like the crossing over in the medullary pyramid. So you will see a lot of like crossing in the lower part of the medulla, because that's where, like, this is where the pyramids are in the caudal medulla. So not as much as like heavy on like the nuclei, but definitely a little bit looks like a spinal cord cross section. So this, for example, this looks like a butterfly as soon as I'm looking at it, and I'm like, yeah, this is called the inferior olive, or the olivary nucleus. It's a very, I didn't point it out, inferior olivary complex. This is involved with like hearing, and it does stuff with like hearing coordination. It does look just like a squiggle, and so I'm like, oh, I see that. I'm like, cool, rostral medulla, like I know I'm here. And then here's it labeled, and then now this kind of looks like a spinal cord cross section. Like, it really looks similar to one. But if they're telling me it's a part of the brainstem, I'm like, all right, it's probably the medulla, but it's going to be the caudal portion. And then here's it labeled. And then here's the pyramids down here. Remember, the medullary pyramids, that's where a lot of the decussations are occurring. So if they even they label this and say this is a pyramid, you're like, okay, I'm in the caudal medulla. All right, almost done. A few more slides. So, and then I want to do one question with this method, and then that's enough. That's plenty. But brainstem blood supply. So kind of thinking of it, if you think of any of these portions as a medial portion, a lateral portion, here's the blood supply. So we talked about this. So remember, PCA does lateral and medial of the midbrain. I actually think this is in Boards and Beyond. I think I just recreated from Boards and Beyond this image. But laterally and medially, the midbrain is supplied by the PCA. The pons, the lateral pons, is supplied by ICA. The medial pons is supplied by the basilar artery. And then the lateral medulla is supplied by pica. And then the medial medulla is supplied by ASA. Okay? So here's Here's the moment that we've been waiting for. The foolproof way of never getting a brainstem lesion question wrong. And I swear, like the second years now, I'm telling you, they're like, I love this method. I'm like, you're welcome, guys. It's fun. Like once you get this down, you're gonna like love doing brainstem lesions. So I call this the tic-tac-toe method. If someone says that they came up with it, they're lying because I literally suffered over coming up with this. But regardless, this is kind of like you draw a tic-tac-toe board, right? So you draw a tic-tac-toe board, and then you just kind of like act like each section of the tic-tac-toe board is a different part of the brainstem. So the midbrain being the entire top part of the tic-tac-toe board, the pons the middle, and then the medulla is going to be the very bottom. Then you establish medial lateral. So medial, remember, is going to be your motor stuff, and then lateral is going to be on both sides. So this would be like the right side on the lateral, and this would be like the left side lateral. And remember, medial and motor kind of go together as well as lateral and sensory. Next thing that I do is before we go into like this approach over here, we're just drawing out the tic-tac-toe board. So we just draw your tic-tac-toe board, midbrain, pons, medulla, lateral, medial, lateral. Next, you can draw on your blood supply because we just talked about it. So PCA does every part of the midbrain. ICA does the lateral portions of the pons. Basilar does the medial portion of the pons. And then medulla is going to do your lateral, the pica is going to do lateral medulla. ASA is going to be medial medulla. Okay? With me? All right. And then next, what I do is I draw in the cranial nerves that are located here. So again, like I said, remember medial cranial nerves are going to be anything that's divisible by 12 besides 1 and 2. So we have 3. So that leaves 3, 4, 6, and 12, right? 3 and 4 are in the midbrain. 6 is in the pons, and 12 is in the medulla. Remember, 4 will never be in a brainstem lesion question ever. You'll never get cranial nerve 4. So I only keep 3. So I draw 3. Then I draw 6, and then I draw 12. These are all my medial guys. And then I go in with all my other ones and I draw them. However, you can't, and this is the rule of thumb, it's tried and true, tested theory. You cannot use cranial nerve 7 to differentiate between lateral and medial. Do you remember why? It's because 7 wraps around 6, or its axons wrap around 6. So technically, you can have a lesion of 6 and it can damage the axons of 7. So you can actually be doing a question and then see that like there's facial paralysis and it's actually a medial like midbrain. It's like a basilar artery stroke. And you're like, wait a second, but cranial nerve 7 has nothing to do with the medial pons. Or I said midbrain, the medial pons. And it's because 7 wraps around 6. So it can just be like collateral damage with 6. So I draw 7 right on the line between medial and lateral on both sides. Cause I'm like, you know what? I know it's in the pons, but I can't use it to differentiate one versus the other. So it goes on the line. Similarly, you can't use 5 and 8 to differentiate. And you know, the reason why for this is because of their nuclei. Their nuclei span so many different layers. Like for example, 8 is in the pons, but it can creep down into the medulla, the rostral part of the medulla. 5 is in like every single one. I mean, most of them are in the pons, but you saw there's one that's in the medulla that is pretty substantial in the medulla. So I, again, draw them on the line. I draw them right on the line, 5 and 8, right on the line between the pons and medulla. And then 9 and 10 are always going to be lateral medulla, so they're out here. And then everything else is just whatever you want to draw that helps you. So some other things that I draw with my tic-tac-toe board is the cerebellar peduncles. So you have your medial cerebellar peduncles in the pons, and you have your inferior cerebellar peduncles in the medulla. And this doesn't really do much. It just reminds me that you can see cerebellar symptoms with brainstem strokes because we have these peduncles, and I pointed them out earlier. You can also see Horner's syndrome symptoms, which I don't know if you guys got to Horner's yet, but this is just something that I decided to add to remind myself like of the triad of Horner's. You can see it with lateral lesions of the pons and the medulla. And then finally, I drew locked-in syndrome. So locked-in syndrome is really weird. It's no, I didn't talk about it with Man in a Barrel, but it's kind of like locked-in syndrome is if you only have a basilar artery stroke. So if you only have a basilar artery stroke, all the symptoms are going to be you can't move any part of your body except your eyes. You can really only move your eyes, and you can't even abduct your eyes. You can only like move them adduction, up, down. Like you can only do what cranial nerve 3 and cranial nerve 4 do for it. So they call it locked-in syndrome because you're sitting there like locked in place, and the only thing you can do is move your eyes. You can't speak. You can't do anything. It's a really crazy thing. That's called locked-in syndrome. So I just drew it on my tic-tac-toe board, but you can draw whatever, you can put whatever else you want in your tic-tac-toe board. But And we're going to draw it out before we do one of the questions. But how do you kind of approach brainstem lesions is immediately what you want to do is establish ipsilateral or contralateral. And I say using tracks because I just think it's easier than trying to use the cranial nerves to identify ipsilateral or contralateral. You still can use the cranial nerves. Like if you're seeing like left-sided cranial nerve 3 issues, it's probably going to be a stroke on the left side. But I also like to use like your corticospinal tract or your spinothalamic tract because I know that can kind of help me, those like long tracks. But this is really important to establish, however you want to do it, establish ipsilateral or contralateral immediately because then you can cross certain things out in your answer choices. If you know it's on the left, you can cross out anything on the right. It's less to look at for the answer choices. Then use the cranial nerves to help you identify not midbrain, brainstem segment location, and then if it's medial or lateral. Okay, and here's what I mentioned earlier. You can't use 7 to differentiate medial and lateral. That's why it's on the line. You can't use 5 and 8 to identify between pons and medulla. Again, just because they're massive nuclei and there's a lot of them. And then also you can use like I said, the lesion tracks. Like however you want to do this will work. And I want to show you. So I want to do one question, just showing you how to do it. We're going to do it together, and then you can practice it using the other questions in here. So how I kind of approach this, first of all, I kind of like see like they're asking what artery is occluded. They're asking what's the lesion. And a lot of your questions on your exam is going to be like, what's the lesion? And remember, like I said, I mean, all of these are pretty much like brainstem arteries, but remember, does it sound like a brainstem artery or does it sound like a cortical stroke? That's going to be like a big thing you're going to have to try and do as you're starting to do questions. But we know that this is a brainstem lesion, I told you guys. So 70-year-old male presents with nausea, vomiting, and vertigo. So automatically I see vertigo. I'm like already thinking cranial nerve 8. So I'm going to just like draw it in here. But I just kind of like, as I go, I kind of draw it. I can take things out, whatever. So weakness on the left side of his face. So I have left-sided weakness. This could just be like because he had a stroke, right? Like you have these signs when they have a stroke. So I wouldn't write anything there as of right now. So they happened the day before. He has symptoms like he has risk factors for a stroke. So I'm like, okay, I'm on the right track. It is a stroke. So neurological exams reviews hemiparesis of the left side of the face, decreased lacrimation and salivation to the left side, and difficulty hearing on the left side. So now it's starting to give you some of these, those cranial nerve symptoms again. However, there is no weakness in any of the extremities. This is them basically telling you that this is not a cortical stroke. Because remember, with cortical strokes, you always see like that contralateral hemiparesis, always. And it just depends on the homunculus, if it's like the ACA, the MCA, the PCA. Well, the PCA is usually eyes, but like ACA versus MCA. Just confirming we're talking about the brainstem. So now there's analgesia on the left side of the face and right side of the body, but tactile sensations like pressure and vibration are unaffected. Again, our long tracts, our like spinal cord stuff are completely unaffected. When asked to protrude the tongue and say, he is able to do so without deviation of the tongue or the uvula. This says it's a stroke due to occlusion of the artery. What's the artery? Left and right's always going to be on there. And then it's basically like, all right, what part of the brainstem? Like which artery is supplying which part of the brainstem? So you draw your tic-tac-toe board. We know midbrain's going to be up here. We know that this is going to be PCA in both lateral and medial. I'll just draw P and P. We know lateral pons is going to be ICA. Medial pons is going to be basilar. And then we know medulla is going to be pica laterally. And we know that ASA is going to be medial pons. No, medulla. Cranial nerves. So we know 3 is here, 6 is here, 12 is here. We know 7 you can't use to differentiate medial and lateral. We know 5 and 8 you can't use to differentiate pons from medulla on either side. And we know 9 and 10 are down in the lateral areas here. All right, so then kind of going through this, you can kind of, first of all, like establish ipsilateral, contralateral immediately. A lot of his cranial nerve symptoms are on the left side, a lot of them. So this is on the left side, this is on the left side of the face, and then right side of the body, this tells me that this is a long tract. So automatically I have left-sided cranial nerve symptoms and a long tract on the opposite side. This tells me this is a left side. So anything that says right, it's out. So it's out, it's gone. It also tells me that, so when asked to protrude the tongue and say, there's no deviation, that's 100% a cranial nerve 12, like 100%. That's a medullary area. We cross out anything that has to do with the medulla. So anterior spinal, that's down in the medulla. Pica, that's down in the medulla, out and out. So now with just not even doing cranial nerve stuff, some cranial nerve stuff, we've already just narrowed it down to two things. We have a basilar artery, which is going to be medial pons, and then we have Ica, which is going to be lateral pons. And if you look and you kind of like, again, look for some of the signs that he has, which I know it gets a little tricky because like a lot of the things for medial versus lateral are like right on the line. But if you kind of look at everything and piece this together, this is going to be more of a cranial nerve. This is going to be more of like a lateral pons lesion. Okay. So it's going to be more of versus like a medial pons lesion, which would be a lot more like, horizontal nystagmus and issues abducting the eye, and, maybe facial nerve would be involved, maybe because 6 and 7 are super close to each other. But like nausea, vomiting, vertigo, issues with the face, lacrimation, which is tears and stuff. We didn't talk about it. I didn't really bring it up, but that's another reflex involving cranial nerve 7. So that's going to be, this sounds more like a lateral pons. And then they do talk about there's analgesia. So like, sensory deficits on the right side of the body. Sensation is a lateral thing versus a medial thing. So it more so sounds like it's more of like a lateral pons versus a medial pons. So that's how you kind of get to like your your Ica versus like your basilar artery. Okay, and then it kind of goes into it. This is lateral pontine syndrome. And I just wanted to show you, I really liked this comparison from this question. I don't even remember where I got this question. But Ica versus Pica. And then it talks about all the potential nuclei that could be damaged if you lesion one of these arteries, and then how it would present clinically. Because again, what gets tricky about some of these brainstem stuff is not the actual cranial nerve itself, it's the nucleus. And the nucleus might be all over the place, honestly. And that's, again, why you can't use 5 and 8 to say, like, I'm definitely in the pons, because their nuclei are massive and they span multiple regions of the brainstem. All right. I hope that was helpful. And then go through and do all the questions. I threw in some cortical strokes in here too, so you guys can kind of see how that compares to like a brainstem stroke question. But sorry, that was like super, super chaotic. It's just a lot to cover in one session. I'm glad it was helpful. I will upload this. And yeah, hope you guys have a great rest of your night. Bye.